These are the folks. There's a row back there. Kathy and Melissa and Sam and Gabby, and they had a great session earlier on to yesterday. And the TM, as you see here, radiation oncology. Just a shout out to James and to Dan for helping with this. Our imaging group, Scott Lucia could not be here from pathology. Niraj, thanks very much. Peter will be going later on today, and Jessica McDermott, who is our diversity, equity, inclusion, and integrity. Is that what's the other I? Integrity? Yes, integrity. Our oncology nurse professionals, our data coordinators, and our CRA liaisons. These are the folks who do all the work. So thank them for all the work that they do for us. Pharmaceutical sciences, our patient advocates. We'll have some, Rick, are you here? Rick, why don't you come on up? We're going to take a moment here and do some introductions of folks who are with us, leaving us, and joining us. Rick, as you know, is our lead patient. He's the chair of the patient advocates committee, is also our bladder advocate, but come on, man.
So as many of you know, we were exhausted after the global search that we did for Laura. And so Tony and I are terming out. I put in term limits, by the way, so we can blame me for this. All right, so 2 5-year terms, that's the way it works. And so he and I are rotating off. We will be in an emeritus role for 6 months, so that does not mean we're completely abandoning you. All right, so we conducted another global search, this time for 2. And through miracle of timing, I don't know how we pulled this off, but both were, we found 2, and they are here at the meeting. So we are pleased to see them. So Daryl Nakagawa, would you want to stand up? Okay. So Daryl will be my replacement. And Daryl has a strong relationship with Beacon. He's a survivor as well. And Karen Costello will be our prostate advocate. Okay, Karen's husband is a prostate cancer survivor. And these folks have very strong CVs, so I'll work to get the announcement out to you specifically so you can take a look at their credentials, but trust me, they are quite strong, and they were vetted through the subcommittee chairs. So welcome them. They're looking forward to, they're really excited. They're drinking from the fire hose, however. They haven't even been onboarded or oriented, but we did get them to the meeting. I want to point that out.
And if we could take a moment to thank Tony and Rick for all the hard work that they've done over the years. We have an extraordinary track record of remarkable patient advocates who play a major role in the success of what we do. Our organ site chairs who will be leading this. These are our registrations that you see. We're working hard to ramp up our accrual. Important to call out to the Hope Foundation, which has made many of these things possible. The Impact Awards, all the data analyses, please go to the Hope website. And if you look in your book, which I left over there, there is a QR, what do you call it? QR code, thank you very much. A QR code, snap on that. And if you would like to contribute to the Vogelzang scholarships, to the Hope Foundation, much of what is possible through the GU committee is made possible for them. The Young Investigator Training Course, which has led to a number of the careers of folks within the GU committee. Honoring Nick, we had the symposium this morning. And earlier, thanks to Tom Flagg. Thank you very much, Tom, for helping chair that committee that made the decision. I know it was quite a difficult decision to be made for the number of applicants, but Laura, I know, is here. Laura's standing back in the back. Laura, different Laura. There's 2 Lauras. Laura, our patient advocate, and Laura Graham, who's our Nick Vogelzang scholar, and Jack Andrews, I believe, is here as well. Jack standing in the back. Please congratulate Laura and Jack. Now, the other responsibility for all of you who are here and all of you who are online is to love on Laura and love on Jack, make them feel very much at home, take them out, buy them a drink, get them dinner, get them completely involved, because as you know, your first time in the GU committee, it seems like it's overwhelming. How does this whole process work? But to sit down with them, and Laura and Jack, if you don't know somebody, go up and talk to them and find out who they are. Our expectation is that you will be overwhelmed by the collaboration. We want to make you successful. We want you to be the folks that become the organ site chairs, group chairs, and so forth. So welcome. Nice picture of Nick. Oh, I already said that. And here's the QR code. I remember it, the QR code that you can snap on, but it's in your book, report of studies. Please click on that and please contribute. I intend to, in perpetuity, continue to do so. Nick was just a remarkable guy. Final thing for me, just so we can be on time. Don't forget that investigators who are considering serving as a study chair are subject to the SWOG conflict of interest policies. If it exceeds more than 5,000, a management plan is instituted. If it exceeds 10,000, you can't serve as a study chair. So be very, very much aware. If you have a study coming through the pipeline with a pharmaceutical, with something else, just be aware, probably best to avoid that conflict so it doesn't even come up to the conflict committee. And if any questions come up, dsparks@swog.org. That's Dana Sparks. She's an expert. She can help you navigate through that. And as a reminder, to get the emails about the GU committee, you have to be a GU committee member. Please email SWOG operations office for questions with regards to that. And without any further ado, our prostate folks are on. Let's stay on time. While you're chatting.
Hi, welcome everyone. Thanks for joining. And in order to stay on time, anyone who sent me slides, you know who you are, be ready to jump up when we call on you, please. So really a warm welcome to our new patient advocate for prostate cancer. We're very excited. So this is the order. Take a quick look, find your name, and that way you'll have a sense of when I'm going to be asking you to pop up. I wanted to just touch briefly on diversity, equity, and inclusion initiatives. We had our symposium last year at the spring meeting. Jessica McDermott is here, I hope. Yeah, everyone's note Jessica, if you have any ideas for DEI initiatives, she's really our GU champion for that. We've been asked not to roll out some of the ideas that we had talked about until SWOG as an organization rolls out their initiatives, but I don't want us to be doing nothing in the meantime. So truly, if anyone has ideas, please email me, email Jessica, email Dan. Some ideas, you know, at the symposium last year, we saw that it's important that within our committee, the membership, the people leading these trials and designing these trials, that we have diversity, and that takes mentorship through an entire pipeline. Not only fellows, but even earlier stage career folks. If we have ideas of how to make outreach and encourage a pipeline, please let me know if that's something you're interested in. In terms of clinical trial diversity, what we heard last year at the symposium was it's not just about getting the patient on the trial, but making them feel a part of the research, you know, respect and integrity. So how can we do a better job of that in our trials? How is participation different? So how can we make inroads out into the communities and get those patients in our doors so that they have the opportunity to participate in our research? So if anyone has any ideas, any initiatives around this, please reach out. Otherwise, more specific initiatives are going to be rolled out group-wide. All right, so Brian, you are up first.
All right, good afternoon. So just a quick update on where we are with SWOG 1802. We just had a nice conversation about this in the prostate meeting. If you recall, this is the study design. A couple things I want to point out that were brought up earlier today is we're pretty loose on what we're requiring for a definition of metastatic disease. If someone has a PSMA PET scan and the PET scan, the CT portion of the PET scan shows positivity, that's sufficient enough. If it's PSMA PET alone, it does require a biopsy confirmation. If someone has less than 4 metastatic sites, they can have metastasis-directed therapy if that MDT is completed prior to the randomization time point. As you know, the primary objective is overall survival, and we have a number of secondaries, including the surgical excision group, specifically why we have a cap built into the radiation number of patients. That cap at this point is, if it's going to remain in place, will be met in the spring of 2024. So just to keep that in mind, and we'll update you about that as we move along. This is where we are currently. About 674 patients enrolled to the study. 470 of those have been randomized. This gives you an idea where there were some lulls in enrollment, and so we've had 2 consecutive double-digit months, and I hope that continues. As we talked about earlier, this study is at risk for not being able to fulfill its enrollment. So we do need sites that are not participating to participate. If you are participating and you need some support in order to try to enroll more patients, please reach out. We're happy to discuss and review any of these things with your groups. To give you an idea of the patients that are currently enrolled, we do have about 50-50 split on oligometastatic versus polymetastatic patients. And currently 2/3 of the patients, or 63%, have received radiation and 37% have had surgery. We do have enrollment aids, including a video, which goes over this at a patient level. So please reach out to anyone from the SWOG group or the S1802 email if you need that video access. If you Google it, it shows up on YouTube. There's the protocol specific materials are available, as you all know. So this is the email for the SWOG. This is my office phone number. I'm happy to give out my cell phone number if people would think it's helpful. And I'll leave it open for any questions or comments.
Yeah, any questions? We had a really nice discussion at our closed session just now about any other questions in the audience, concerns. Everybody have it open at their sites?
Right.
Okay, great. I mean, we did learn that there's 140 sites open, so we got to get this on the radar for everybody. And we'll be doing some more strategies here in the spring. So, you're right.
All right. So next study is SWOG 1216. We completed this study, total of 1,300 patients, and this is what SWOG is about. We help each other. So the reason for this presentation is to first thank you to all the high enrollers and everyone who enrolled. And we can continue to do that with, these are old slides, sorry. So these are the top enrollers across the board. So let's keep pushing for SWOG 1802. Hopefully we'll enroll that study in next 1 or 2 years. The second reason for this presentation is to re-emphasize on the utility and value of correlative markers. We have been publishing many good impact papers, and let's continue. It is extremely important to collect progression samples, as Amir will agree with me. So this study was just published in European Urology, led by Dr. Lara, regarding the bone markers, and these are really pertinent findings. Hopefully these will be used in the biomarkers, in the design of biomarkers down the line. This is the study by R01 funded study by Amir Goldkorn. Again, very important to collect progression samples whenever these patients have disease progression. Let's not forget about them. And then last thing is what I learned with some mistakes, that we cannot do post hoc analysis of this large trial. So this is a 1,300 patient data, and a lot of analysis can be done, but we cannot do that until all the pre-specified analysis are already reported. So we will be reporting the last pre-specified analysis in this coming ASCO, which is PSA, correlation of PSA and the survival outcomes. And it will be a nice paper. Dr. Mamta Parikh is leading that study. But after that, we'll be able to use this data, this large data set for post-hoc analysis. So if any of you have young investigators who really want to work on these data sets or these data, please contact me. Thank you very much.
You can also join us on our Friday once a month calls to workshop some of those ideas.
All right, good afternoon, everyone. It's so nice to see everyone again in person back in San Francisco. Welcome all the new folks. Look forward to meeting and working with you. So I'm really pleased that we are extremely close to being able to activate SWOG 2210, which by way of background, let's see, here's the title, Neoadjuvant Carboplatin for Localized High and Very High Risk Prostate Cancer with Germline BRCA1 and 2 mutations. By way of background, patients with localized high-risk prostate cancer have about a 50% chance of disease progression after radical prostatectomy. Germline BRCA1 and 2 carriers with localized prostate cancer treated with curative intent have poorer outcomes compared to their counterparts who do not carry the same mutations. Neoadjuvant systemic therapy is not currently standard of care for prostate cancer, but next generation AR targeted agents are being explored. And BRCA1 and 2 mutations confer sensitivity to DNA damaging agents such as platinum chemotherapy and PARP inhibitors. Carboplatin is well tolerated, familiar to many in the oncology community, maybe not at the moment, but generally widely available and considerably less expensive. And so presents an opportunity to be leveraging the strength of SWOG and the NCTN. Neoadjuvant systemic therapy is standard of care for other BRCA1 and 2 mutation-associated cancers such as breast, ovarian, and pancreas. So the hypothesis of the study is that 12 weeks of neoadjuvant carboplatin chemotherapy followed by radical prostatectomy for men with localized high and very high risk prostate cancer and who carry germline BRCA1 and 2 mutations will result in meaningful pathologic complete responses and facilitate deeper translational understanding of biological treatment effects. And we'll have opportunities for biomarker or other translational investigations. So here is the current study schema. As I mentioned, high risk, very high risk prostate cancer and germline BRCA1 and 2 mutations. I will emphasize people can come in already knowing about their mutation. So it's not a requirement to learn it after they have their diagnosis. But certainly, you know, we've talked at length in the closed session about really thinking ahead about how to streamline workflows. And I guess the request to you, if hopefully you'll be interested in the part of your patients, but also to think about working with your genetics folks and your urologists and trying to streamline those workflows. And we have some thoughts about how to help you. Every clinic and practice has different strengths and resources with respect to genetics, but we want to ensure that this is feasible for everyone and that we help move the needle for implementation, because I think it'll pave the way for other precision oncology efforts that may be multidisciplinary in the future. I won't spend too much time on that. So key patient eligibility, just to highlight again, very high risk disease, clinical T3 or grade group 4, grade group 5 or PSA 20. I will mention prior ADT, if applicable, is allowed and may have been initiated up to 90 days prior to randomization. And metastasis directed by PSMA PET is permitted if no metastases are seen on conventional imaging and that our surgical colleagues deem that all of the sites that are detected are resectable. And then local lab are sufficient for eligibility as long as it's CLIA certified. So any germline BRCA1 and 2 test, as long as it's CLIA certified, will be permitted. And again, prior knowledge of mutation is allowed and in fact encouraged when it's known. Thanks to our statistical team, Kathy, Tangen, and Tham, we have this 2-stage design. The pathologic response probability of 30% or greater would be of interest in this patient population, while further testing would not be pursued if the response probability was 5% or less. And so we plan to enroll 20 eligible patients to receive protocol treatment. And then I won't go through all the details, but 12 or more responses out of 20 would be considered evidence warranting further study of the regimen, provided good tolerability and other metrics appear favorable. And the total sample size target is 44 patients. Here, the summary of the endpoints: pathologic complete response or disappearance of all invasive cancer after completion of neoadjuvant treatment by local pathology report. The secondary endpoints are listed. They're 2-year, 3-year, 5-year biochemical-free survival, metastasis-free survival, and overall survival. And we do have plans for translational correlatives, including tumor second allele inactivation, HRD signature, IHC, and hopefully ctDNA signature for detection of recurrence. So here's a schema again. I think the call to action for you is really to get ready. We're very, very close. So think about your genetics testing workflow, talk to your genetics team, talk to your urologist, try to shore up those communications, let us know, let me know, let Dr. Sokolova know. If you have questions, Dr. Pillier, we're trying to develop workflows and toolkits for you. So understanding what's available and what we can do to help and what you need would be really helpful, and we can work together on those things. So stay tuned for the final protocol. Thank you so much for your feedback and your support.
So we'd really like to hear from you, any concerns you have as this trial approaches activation, because we really want this to succeed from early after activation. So please feel free to step up and speak up.
Aaron Stoves, but my question is, what do we mean by adequate organ function?
So there's a list of sort of making sure that, you know, there's enough red blood cells, white blood cells, that
So there's like
function
a,
is,
there's like a
yeah, it's just, it's
list
for
everybody in
safety.
the room would agree
Yeah,
on the
yeah,
list? Okay,
yeah,
I just want
It's
to
a
make
good
sure, 'cause
question.
from the
Yeah.
patient point of view, they won't know what that means.
yeah. Just make, it's ensuring that for the patient, it's a safe treatment, that we're not putting anyone at undue risk. Good question. Other questions or comments? Okay, thank you so much.
Next is Earl, presenting a cross disease organ trial.
Okay, good afternoon, everybody. I'm Earl Burgess. I'm going to speak to you briefly about SWOG 2012, which is a randomized study that's assessing the impact of adding atezolizumab to standard of care platinum etoposide backbone for patients with poorly differentiated extrapulmonary neuroendocrine carcinomas. David Jen from the University of Washington is the study PI, and I serve as the GU liaison. So we know that only about 10% of neuroendocrine cancers originate outside of the lung. And of those, roughly a third have an unknown primary. And of the third that do not originate from the GI tract, roughly half originate from the GU tract, primarily the bladder and the prostate. Because of the rarity of extrapulmonary neuroendocrine cancers, the treatment paradigms are extrapolated from small cell lung cancer and are based primarily on platinum and etoposide chemotherapy. The Empower 133 trial, which added immune checkpoint inhibitor atezolizumab to standard platinum etoposide, showed improvement in outcome for patients with extensive stage small cell lung cancer. Similar outcome was observed with the use of durvalumab in the Caspian trial. And these two studies changed the standard of care and established that the use of chemoimmunotherapy is the appropriate first-line treatment for patients with extensive stage small cell lung cancer. Those studies served as the basis for this trial, SWOG 2012, which is a randomized phase 2/3 study, which is assessing the impact of adding atezolizumab to standard of care platinum etoposide chemotherapy for patients with poorly differentiated extrapulmonary neuroendocrine cancers. I've shown the schema here. It's a 3-arm design. In the first arm, atezolizumab is added to induction platinum etoposide chemotherapy, followed by 1 year of atezolizumab maintenance. The second arm adds atezo only to the chemotherapy portion without maintenance, and the third arm is standard of care platinum etoposide. Overall survival is the primary endpoint, and it's hierarchically tested. When the study first opened, it only allowed small cell histology. However, an amendment was approved earlier this year, which broadened the histologic eligibility to all poorly differentiated neuroendocrine carcinoma subtypes that do not originate in the lungs, so large cell, small cell, et cetera. I just want to mention a few key study logistics that I think would be of interest to the GU community. I've mentioned that the histologic requirement is for the presence of poorly differentiated neuroendocrine carcinoma. IHC for neuroendocrine markers is considered optional. Any patient with prostate cancer who has suspected treatment emergent neuroendocrine prostate cancer would require a rebiopsy confirming the presence of neuroendocrine carcinoma. And CTs are required for study screening. PET scans are not allowed for screening purposes. Couple of comments about prior allowable therapy. So any patient who may have had non-metastatic high-grade neuroendocrine carcinoma at presentation who received definitive treatment with platinum etoposide and consolidation with radiation or surgery are allowed as long as definitive therapy had occurred 6 months prior to registration. As you know, often these patients are symptomatic and require urgent initiation of chemotherapy. So the study does allow for one bridging cycle of platinum etoposide prior to registration. Any patients who may be on denosumab for skeletal protection have to be switched to bisphosphonate prior to registration based on the hypothetical immunomodulatory properties of denosumab. Any prior immune checkpoint inhibition for alternate histologies, so specifically urothelial carcinoma, is allowable as long as it was completed a year prior to registration. And prior ADT or docetaxel for treatment of prostate adenocarcinoma is allowed. On study, concurrent medications include continuation of ADT and androgen receptor inhibitors. The use of steroid-containing regimens is disallowed, so abiraterone and prednisone would not be acceptable. The study initially was slow to start enrollment, but following the amendment that broadened the histologic eligibility is now tracking along with what the original projections are. So in conclusion, SWOG 2012 is the first prospective study that's assessing the impact of adding immune checkpoint inhibition with atezolizumab to standard of care for patients with poorly differentiated extrapulmonary neuroendocrine cancers. As I mentioned, David Jen is the study PI. Either of us are happy to answer any questions you may have about it. I hope you would consider opening it at your site. Thank you.
Question, Dan?
So a couple questions. Firstly, would this include small cell bladder?
It does.
It
So
does.
small cell bladder and mixed histology. So mixed urothelial small cell.
So the other question is, often we see small cell carcinoma exist with adenocarcinoma at the same time. Do you have a cutoff for the percentage of small cell? Let's say if you rebiopsy that lesion, it's half small cell, half adenocarcinoma.
There's no requirement for the percentage of neuroendocrine carcinoma, as long as it meets the WHO criteria for having poorly differentiated. So in the biopsy, if it's 10%, there's no limit to the amount of neuroendocrine.
And is it limited to small cell, or can it be neuroendocrine differentiation? So there's a lot of different nuances to that diagnosis.
Any poorly differentiated neuroendocrine using the WHO histologic criteria is allowable.
Great.
Chris?
It's not working anyway. Who has this trial open? That's what I was worried about. So if you look at the breakdown, gee. Right. And so that's my point exactly. It's multidisciplinary. So you may have it open in your institution, might not even be aware of it because it was kind of geared towards GI neuroendocrine at first in concept, but it's open. GYN, GU. So look around at your institution and feel free to be the vanguard to open it for your GU patients there and invite others to participate.
Thank you for raising that point. So we're polling the prostate subcommittee now and taking feedback to the study PI. And there's been a lot of discussion in terms of coordinating at your institution. To your point, there's only one PI, and so it requires discussion with the other disease sites that may have patients that would be interested.
Thanks. Paul?
Good afternoon. Thank you very much. I wanted to give an update on the concept of a phase 3 study of cabazitaxel with or without carboplatin in patients with metastatic castrate-resistant prostate cancer stratified by aggressive variant signature. The first thing to tell you is we now officially have a study number, which was very exciting, and time's limited, but I wanted to thank members of the GU Prostate Committee and the SWOG study group who've really proven to me without a doubt, it takes a village. So I'm going to focus just on a few concepts that, again, having presented this before. So this work is built off this notion that we've recognized in the clinic a subset of prostate cancers in the castrate-resistant state that are very aggressive. Clinically, they often will behave like small cell or neuroendocrine carcinomas, but interestingly have adenocarcinoma pathology. So we first initially characterized them on a series of clinical criteria established by Anna and Dr. Logothetis, looking at visceral lytic primary bulky tumors and short response to androgen deprivation therapy. And then in some work subsequent to this, where these tissues were characterized, came up with a proposed molecular signature we're calling the AVPC molecular signature, which is a combined loss of 2 out of 3 tumor suppressor genes, P53RB and P10, analyzed by IHC or genomic sequencing. And in a randomized phase 2 study of 160 patients in a post-hoc analysis, we actually interestingly found that the presence of the signature was most predictive for benefit to the combination, meaning those patients that had the AVPC were more likely to benefit from the addition of carboplatin to cabazitaxel. So from this work, we wanted to now prospectively test the value of the marker in a randomized phase 3 study, with the principal hypothesis being that the addition of carboplatin to cabazitaxel will significantly improve radiographic progression-free survival compared to cabazitaxel in men with AVPC positive tumors, but not those that are AVPC negative. There was some very valuable input I've gotten from various meetings to present this work. I just wanted to highlight some of them that we appreciated with the rapid advent of new therapies, including lutetium, that we needed to be a little bit permissive on number of lines of prior systemic therapy. So we have this concept now of lines. So if you've gotten, for example, abiraterone and darolutamide, we're not going to count those as 2. That would be considered 1 line. We've extended the available tissues to be up to 12 months prior to registration. Again, we wanted to try to create some buffers for using tissues that wouldn't be too restrictive. We've also changed the eligibility to include prior docetaxel, appreciating that that will work out for most people's insurance. We're going to be looking at some blood-based biomarkers, and I look forward to developing that further with the TM committee, Amir and David as well, so that we really hope to bank some samples that will be of use to the SWOG community and other investigators very motivated to do that. So couple things that I've been spending most of the time on in the last few months, and certainly since our last meeting, is to try to establish the workflow for determining the signature, which we consider to be an integral biomarker as it's used for purposes of stratification. So the AVPC molecular signature can be determined by IHC in a CLIA certified environment. We are also including the possibility of doing so by genomic sequencing, but we're limiting that to solid tumor analysis rather than ctDNA, as has been pointed out by others. There's some challenges with ctDNA, I think, given issues with concentration and other things. What we're trying to work on now is kind of a workflow. So I wanted to describe that very briefly to you. So patients will register. The first step will be to assess the AVPC molecular signature. We plan to do that centrally at MD Anderson through a CLIA certified lab. So we have now a group that I'll show you in just a moment, and an application for a translational medicine application with BIQ funding that we hope will help this. But we want all eligible patients to be able to be stratified by either the presence or absence of the signature. Again, a second step with randomization between the 2 treatment arms. We also discussed, again, having the option for patients to be enrolled, at least initially, for randomization based on local assessment of the signature, which I think would most likely occur through CLIA certified genomic sequencing platforms. And we thought to do this really because of the urgency that these patients sometimes require to get on protocol sooner rather than later, because they're often can really need aggressive treatment quickly. But the idea is that we're going to require all patients, even those who were determined by the sequencing to eventually have all their specimens submitted for central IHC at MD Anderson, because that's what we'll be using for the statistical analysis. I think there's several features that we hope will lead actually to a reasonable turnaround time. I can imagine most of us have had some experience with and can be apprehensive, but I think that we really hope to deliver on this in a timely manner. The IHC turnaround is not particularly lengthy. We're going to have samples shipped directly to MD Anderson for the initial analysis, and then leftover specimens sent to the SWOG bank. The fact that we can use tumors up to 12 months prior, we hope will lead to patients actually being considered for the trial, even if they're in the middle of an active treatment. If you anticipate that the trial may be what you want to enroll them on next, those tissues could be analyzed for the presence of the marker, and we're going to work on some ways to develop that. As I mentioned, we've submitted a proposal or plan to for a translational medicine study that we hope to get funding for. And I just wanted to show you again, a little bit busy, sort of the workflow that we've been working on at MD Anderson to get these samples accessed, we hope in a timely manner. We will capture images of these samples again for central review at a later time. But in essence, we're hoping for a reasonably quick turnaround time. These are the pathologists that are helping out at MD Anderson that have joined the team: Dr. Weiling Wang, Dr. Miao Zhang, and Dr. Patricia Troncoso. And again, to review lastly, the statistics, this will be an approximately 450 patient study. And with Kathy's help, again, we're doing combined futility and superiority with a step down approach. We're going to look initially at the AVPC MS positive group to test if there's actually a differential benefit to adding carboplatin. If not, I think that will sort of call into question whether to continue with the remainder of the study. This allows for the same alpha without splitting. We think that about 30% of the patients will be biomarker positive. And again, we're applying for BIQ funding. So thank you for your time.
Questions for Paul? Any questions? Yeah. Pedro.
Great study. Two questions. Any special language requiring prior exposure to PARP inhibitors?
None presently, but I see your point. I guess it makes one think about sort of, cross resistance or things like that. Yeah, you're right. With the data coming out. What are your thoughts about that?
I think you have to account for it.
Yeah. Yeah. Yeah.
I'll enroll.
Fair enough. But yeah, just obviously keeping track. Yeah, maybe stratified. That's a great point. Again, it shows you how quickly things move.
Yeah.
Oh, sorry. Thank you.
Oh, that's
Yeah.
right. There's people on-
Oh, yeah. Thank you.
As far as I know, there's no data with carboplatin in BRCA1, BRCA2s, and that actually would serve a great purpose in
Yeah.
letting us know what to do in a salvage situation. So you may want to just substratify or have a.
Okay. I think that's a great idea.
Yeah.
Yeah.
There's a question. You want to-
Oh, there was a question about,
online. Go ahead.
sorry, regarding this, how about allowing for one cycle of cabazitaxel to be given while we wait for the AVPC molecular stratification? I guess we would have to think about that. I think my preference would be that we hopefully will be able to randomize right away, but I imagine that would be a good sort of troubleshooting possibility, particularly if we're finding low numbers. So we'll have to, or difficulty getting patients on. Have to think about that and maybe discuss that with Kathy.
When they come towards the lines of therapy?
Just repeat the question.
Oh, the question was, if you include PARP, would you count that amongst the lines of therapy? I think we would have to.
Maybe less than.
Yeah, I see your point. That's right. No. Very good. Thank you.
Any other input? Now is the opportunity before this goes to steering committee. We want to have, the
Yeah,
best possible design. So any feedback?
Oh, you're gonna require blocks be sent or just cut slots?
We did put in for, oh, sorry, the question was, would we require blocks or would cut slides suffice? And we put in for both. My intuition would be that most would send cut slides, but I don't know. I haven't had much experience before, you know, and how other sites would view it. But I think the main thing, of course, is we want to be real careful that this is a collective resource, right? I didn't want people to misinterpret that, but
On 1806, out of 300 initial samples, we have 101 blocks. And
Fascinating.
Like,
okay.
so 30% blocks.
Yeah. Did you find that the blocks, there was that the blocks actually more often than not were adequate for analysis, or was there a drop off that some, when actually looked at by a pathologist, didn't contain adequate tumor?
It's only with infantry last week.
Oh, okay, gotcha. I thought.
30% sites were okay sending.
Okay.
And when you said local AVPC would qualify to enter the trial, was that IHC specifically or NGS?
I was thinking NGS. I did a bit of an informal survey about how many places might have these IHC stains up and running at their own shop, and I didn't get a sense that many have, but I don't know the answer to that. So I was kind of thinking it would mostly be NGS, but I suppose we should be open to that possibility. I don't know, by a show of hands, do any of the groups want to state you are doing, you know?
Yeah, we'll state for it, we can send in slides.
I see. Okay. Yeah. Right. I guess my preference would be to have all the staining and analysis and everything done at MD Anderson. And that's really because we're trying to establish or remove the variability in protocols, at least as an initial stage. Of course, the fantasy is that if this all works, it would be something that would be quite straightforward to do in the community. But I think for purposes of this initial effort, it would be best to do it centrally as possible. Sorry. Yeah, another question. Are the predictions for sample size 150 to 300 and the split between the AVPC positive and negative? Okay, sorry. With aggressive clinical biology or any CRPC, does this reflect the eligibility criteria? We generally estimate the split based on our own experience looking at this signature, and certainly not only the phase 2 trial that we studied, but subsequent studies that Anna has done, and even I think some unpublished data from some other studies looking at some of the hormone naive patients. So
Is it any CRPC patients or very high risk patients?
it should be really any,
Okay.
because interestingly, we have found the signature, right, and even hormone naive patients. And so we're not sure quite yet what that means, but it certainly, the preliminary data suggests that that's associated with a poor prognosis. We're testing more here. Is it predictive? We're also testing for prognosis, but I hope it will be predictive for platinum benefit.
Questions?
Any other comments?
Great.
All
Thanks
right.
again. I really appreciate it.
Well, we're doing great
We're
on
doing
time.
great
We're going to
time.
go to our championed
Yeah.
trials. So the first one is Indicate. Unfortunately, Evan couldn't be here.
Evan
but-
couldn't be here. Yeah, I'll just cover this really quickly. So, and actually just real quick comment, 30% blocks is actually pretty good. I mean, yeah, that's surprising. I mean, I think that as we go through, more and more pathology labs are very hesitant to get their blocks out, right? So we're gonna have to be unstained sections. I think that's gonna be the norm. So real quick, these are Evan's slides. I didn't see them online, so I'll just present them really briefly. We have a bunch of champion trials from our other sister and brother groups. So EA 8191 Indicate. Again, this has been presented here before. This is a large study, 800 patient trial. And again, this is in the biochemical recurrent status. And this is the understanding of what is PET negative or PET positive for extrapelvic nodes or metastasis. And so again, 804 patients after they getting a PET between PET negative for extrapelvic versus PET positive. And then the randomization is either standard of care salvage therapy or enhanced with apalutamide in this arm that is still in the pelvis. In the extra pelvis,
It's enhanced systemic therapy plus minus metastasis directed therapy. It's looking like there are, says here, 76 sites approved. There have been 116 patients enrolled. I know that talking to Neha, it's been a little bit slow. The recent accrual has been about 6 a month. I don't know how many is attributed to SWOG. I can get those data from Evan. There are really only other things that he wanted to have mentioned are some key updates in the upcoming amendment. It's awaiting activation. This local METS is just a package, a type of a tracer package, but then their clarification of eligibility. So if a patient has a BCR less than 12 months, so pretty soon after the prostatectomy, the minimum PSA only has to be 0.2. And if it's over 12 months, then the minimum PSA has to be 0.5, also allowing for any standard of care PET that's positive to be put in the trial. And then the only other things, and again, planned updates in this amendment that's awaiting is mostly just sort of logistics and regulatory, removing the PET scanner qualification, allowing PET MRs. We just have a PET MR at our place, and so PET MR is allowable. And then expanding some of the eligibility with regards to standard of care imaging. So any questions on that? Really important trial. Mike?
All right, this one is EA 8171, the multiparametric MRI and preoperative staging and treatment planning for newly diagnosed prostate cancer. It's a pretty simple study. Essentially, they're just using MRI to detect clinically significant prostate cancer and improve selection for patients going to prostatectomy. Primary endpoints were basically they're using it to estimate diagnostic performance of PIRAD scores and then develop prediction models. It's just a single arm study. It's very easy. Most of us will order an MRI prior to prostatectomy nowadays. So it's quite easy to accrue. Their goal was 852. They're already at 726. So there's about 130 patients left to go. So if you have it open, just throw on a few more patients and we can see this through. SWOG has about 84 of those enrollments. That's pretty much about it. If anyone has any questions, let me know. This was a great one for VAs that are starting and kind of an easier one to accomplish if you're doing prostatectomy at VA sites. Thanks.
Great.
Paul, I think you're.
Where did Paul go?
Oh.
Did Paul leave?
Well, this will be very quick. No updates on this trial, but this was charted to cabazitaxel with abiraterone versus abiraterone alone. And I checked in with Christos, and this was the basic schema of the trial, looking at castrate-resistant patients. And you can see the randomization step here. But the good news is that, we contributed a lot to the study. But what they're challenged by is the readout for data maturation is not until October of 2023. So not too much to report, but maybe by the next meeting, hopefully we will. But I think we did very well to help them on this study. So thank you.
Thanks. I think it's always good for us to remember what's coming up, what data to anticipate as we think about what holes there are in the portfolio for prostate. So keeping an eye out on those results. NRG G07, David, I think, was not able to make it. So this is a study for high risk localized prostate cancer, initially very high risk during the phase 1, in which they are using niraparib as a radiosensitizer with definitive radiation. So they have progressed through the phase 1 dose escalation. They just need a couple more patients at dose level 3, and then it will move into the randomized phase 2. So that will allow high-risk patients, and they can get either standard fractionation or hypofractionated radiation. They're randomized to obviously castration therapy along with IMRT with or without niraparib. With the primary endpoint of PSA, as well as safety and secondarily looking at survival and metastases, and exploratory to look at genomics. So this is unselected because, again, you're asking for radiosensitization from the PARP rather than synthetic lethality. All right, 008.
Okay, this is 008. This is Ron Chen's trial through NRG on node-positive prostate cancer. And so the schema is here, node-positive patients after prostatectomy with a detectable PSA. So they can either not have an undetectable, ever go to undetectable, or else have a rising PSA. Any detectable PSA is allowed. And the randomization is RT with or without advanced ADT. I reviewed some of these before. They're mostly just with regards to with allowing PSMA PET, allowing hypofrac and proton therapy, as well as ADT, even with oral ADT. The primary objective is METS-free survival, and just an update of where they are. The target is 586. They're now 146. So, and a large number that was really in the last 9 months. So they're getting much better on accrual. SWOG, I think, has 10 of the 146. And still getting sites up and activated. I know that was a major problem because they launched well, you can see they launched March 2020, so right during COVID. Questions? James, I think James is going to give us an update on this one. Yeah.
I'll just do it from here. Hong Zhang is the SWOG champion. Accrual is going very well in GU09. It's this escalation de-escalation study. Perhaps that's something that we could look at some point in the future. I think targets in the couple thousand range, and they're ahead of schedule, accruing about 40 a month. So going well.
Yeah, you can see their accrual really doing well. Yeah, it's a nice escalation, de-escalation with a common arm. And they'll answer some nice questions with a biomarker driven decipher. Yeah.
And company Verisight is very interested. I think, I can't speak for them, but interested in using Decipher for pretty much any stratification. I think they're always open for studies. And
yeah.
Sadly, the adjuvant post-prostatectomy Decipher driven trial has been shut down, but the Eradicate study. But yeah, Decipher is pretty well validated, and it's now something we can incorporate conceivably prospectively.
Okay. Casper, who's presenting?
Is Manish here?
Just do it real quick.
Not everyone was able to make it, unfortunately. So this is enzalutamide with rucaparib or placebo in mCRPC first line. So this is the study design with HRR testing for stratification. The two main updates, of course, are the Clovis bankruptcy and the less than favorable ODAC recommendation for abiraterone and olaparib, meaning it was restricted to BRCA mutated in their recommendation. Obviously, we don't know what FDA will do with that. So Casper enrollment is temporarily on hold. They will provide drug for patients who are on study. And we will update as we hear updates for those of you who have this open at your site, what the ultimate fate of the study will be, how it will continue. But if you have any questions, please reach out to Manish or RP. Oh, yes, very importantly, this was the most important part. They want your input actually about how to continue the study and design modifications. So if you scan this QR code, you can actually complete a very quick survey. I did it. It's literally like 3 or 4 questions, but you actually have the ability to potentially influence what they are going to do with this study. So I think it's a really great opportunity, and I'd encourage you, if you don't have time to scan it now, or if somehow it doesn't work for you, you can go to the webpage, go.ankr.us/caspar-survey, easy to remember. Or you can just email me after the meeting and I'll make sure you get access to do the survey. Thank you. So for our last, that was all of our championed trials, and we have been trying to bring in at least one concept each time, even in this open meeting, bigger forum, to try to keep it fresh, just to let everyone know the kinds of things we're working on. So today we have Udit Singhal presenting a concept that we're workshopping. So thank you.
Well, thank you so much. For those who I haven't met, my name is Udit Singhal. I'm one of the urologic oncology fellows doing a combined fellowship between the University of Michigan and Mayo Clinic, Rochester. And this is a concept that I've been working on with Todd Morgan, who's the primary mentor here. And this is really a trial that's evaluating the utility of pelvic lymph node dissection at the time of prostatectomy for prostate cancer, and doing so in the context of PSMA PET imaging. And so to provide a little bit of background, obviously the existing guidelines for pelvic lymph node dissection at the time of prostatectomy are variable. So the AUA guidelines actually don't provide a recommendation regarding a limited versus an extended template for lymph node dissection, but they recommend a lymph node dissection be performed in those patients with unfavorable intermediate risk or high risk disease. And then the EAU and NCCN guidelines recommend performing an extended lymph node dissection in those patients that have nomogram predicted risk of lymph node metastasis at various thresholds. And really the reason for the variability among the guidelines is the fact that previous data has shown that pelvic lymph node dissection at the time of prostatectomy has a benefit for staging, but maybe not a benefit for therapeutic for long-term outcomes in prostate cancer. And obviously, node dissection has been associated with multiple different potential complications, including lymphoceles, DVTs, PEs, more serious complications, ureteral injury, vascular injury, nerve injuries as well. And so the goal really here is to potentially consider whether we can de-implement something that may be of low value in prostate cancer at the time of surgery. So there's been a couple randomized controlled trials that have been performed in this space. And so I'll highlight a couple of them here. This first trial was a single center trial at the Memorial Sloan Kettering Cancer Center of over 1,400 patients, in which they looked at a limited lymph node dissection versus an extended template. And they found that there was no difference in rates of biochemical recurrence between the two approaches. There's obviously some limitations to this trial, one being that the extent of limited lymph node dissection was quite similar to the extended template in this trial, as there was 12 versus 14 lymph nodes removed. And there was a high population of those patients with grade groups 1 and 2 disease in this trial. Similarly, there's another trial. This was conducted in Brazil with 300 patients. Again, a limited versus an extended template was evaluated. And again, there was no difference in rates of biochemical recurrence with an extended or a limited template. And then there are now 4 ongoing trials kind of in this space that are, again, evaluating the utility of pelvic lymph node dissection during prostate cancer surgery. So the first trial is the SEAL trial. It's almost 1,000 patients of intermediate and high risk disease that are, again, randomized to limited versus an extended template. Obviously, this is similar to the 2 prior trials that have already been done in this space. There's a smaller trial of 57 patients with nomogram risk of lymph node metastasis, but this trial actually excludes patients with PSMA PET imaging. And then there's a trial occurring at the Martini Clinic in Germany of over 3,000 patients, again, evaluating patients with intermediate risk disease and whether a lymph node dissection needs to be performed in these patients. And this is evaluating, again, a limited versus an extended template, and also in some scenarios, omission of pelvic lymph node dissection versus an extended template. And then an accruing study now in the Netherlands is the PSMA Select trial, which is of 740 patients. In this trial, patients are randomized either to a control arm or an intervention arm. In the control arm, all patients undergo lymph node dissection and extended template. And in those in the intervention arm, if they're PSMA negative, will actually get omitted a lymph node dissection altogether. And so in this trial, they're actually trying to de-implement or understanding whether the implementation of lymph node dissection is feasible in this setting. And so really, we wanted to, again, evaluate whether omission of pelvic lymph node dissection or maybe a targeted lymph node dissection would be non-inferior to performing an extended template in patients with intermediate and high-risk disease. And the goal would be to assess long-term oncological outcomes in this scenario. And so there's a couple different types of designs that we've looked at. I'll present the 2 most relevant ones here that we feel would probably be best to proceed with if we we're going to proceed with this trial. And so in this first schema, there'd be patients with unfavorable intermediate or high risk prostate cancer who would undergo PSMA PET imaging. If they have a PSMA PET that's positive outside of the pelvis or the lymph nodes, they'd really just be excluded from the trial and potentially just be in an observational cohort. And those patients that have PSMA PET positive disease in the lymph nodes, they would then be randomized to either just a targeted lymph node dissection versus an extended node dissection. And so a targeted node dissection in this scenario is for example, if a patient that has an obturator node that's positive on PSMA, then they would undergo an obturator lymphadenectomy versus an extended node template. And in those patients that have negative PSMA PET imaging in the lymph nodes, these patients will be then randomized to omission of lymph node dissection altogether versus an extended template. And in the second type of design, it's a very similar randomization. Again, patients with unfavorable intermediate or high risk prostate cancer will undergo PSMA PET and then be randomized based on their PSMA PET stratification to either an extended lymph node dissection or a PSMA directed kind of de-escalation of their lymph node dissection, either with omission or again, a targeted lymph node removal. And so the differences between these two schemas is just that this second one here would have just one primary analysis in which you're evaluating a PSMA directed lymph node dissection, de-escalation of lymph node dissection, either with omission or targeted node dissection versus an extended template. And this previous one, there'd be two primary analyses where you're evaluating omission of lymph node dissection with an extended template, and again, a targeted lymph node dissection with an extended template. And so in this study, we hypothesized that in patients without distant metastasis on PSMA PET, omitting a lymph node dissection altogether or performing a targeted lymph node dissection would result in similar rates of biochemical recurrence, metastasis, and prostate cancer specific death, with a lower rate of complications and morbidity to patients. In terms of our inclusion criteria and exclusion criteria is quite self-explanatory. We include patients with NCC and unfavorable intermediate or high risk disease, and then exclude those patients that have had prior systemic therapies or some sort of pelvic lymph node dissections. And our proposed endpoints here would be really a metastasis endpoint. Previous trials in the space and the ongoing trials are all looking at biochemical recurrence. Obviously, we know that biochemical recurrence has limitations as an endpoint, a surrogate endpoint in prostate cancer. And so ideally, we'd like to evaluate MFS, but by conventional imaging, obviously, that's something that would take quite a bit of time in patients, even with localized high risk disease. And so it makes it a little bit less feasible. But we've looked at PSMA detected metastasis as a potential endpoint that may be a little bit better than BCR, but maybe not quite as robust as MFS by conventional imaging. And there'd be multiple different secondary endpoints, including time to secondary treatment, PROs, and then obviously complications and adverse events. There'd be a host of exploratory endpoints that we could evaluate, including collection of blood, urine, and tissue for correlatives, evaluation of various PSMA PET-based parameters, and others as well, especially as such as cost-effective analysis of undergoing de-escalated lymph node dissection versus an extended template. And so for that first kind of schema that we have here, our preliminary sample size calculations suggest that for PSMA detected metastasis endpoint, you need about 1,200 patients or so, 1,250 patients. And then for and this is again for a non-inferiority type design. And then in that second schema that I shared, again for a non-inferiority approach with the PSMA detected metastasis endpoint, it'd be around 1,900 patients. And so really excited to get everybody's feedback and thoughts, and happy to answer any questions.
Questions or feedback?
So we really, really need your feedback, positive or negative. The goal, Pedro, go ahead and step up to the mic. The goal is to see what's the enthusiasm. Is this a question we think is important? Is this something we want to invest in? So please.
Thank you, Tanya. So the question is regarding what are your thoughts post salvage with systemic therapy? If you mandate, nobody goes on it because it can be very different, right? Yeah. And since your endpoint, I believe, is PSMA free survival, PSMA METs free survival. Yeah. What are your thoughts about that?
Yeah, it's a great question. The question that comes up basically every time we talk about this, but I think what we're thinking maybe the right way to approach this would be to restrict adjuvant therapy in the postoperative settings, set a BCR threshold at a PSA level of 0.1 or so a lower level of BCR threshold, and then mandate some sort of salvage therapy standard of care salvage therapy by a PSA of 0.5 or so. And that way patients can get salvage therapy, but providers would basically have to be comfortable restricting adjuvant therapy in patients, until their PSA reaches, 0.1 or so.
Can you go back to that scheme slide?
Of course.
Thank you. So, overall, I like the idea, but I'm thinking from a patient point of view, would you be presenting this study before the PET scan or after the PET scan?
That's a good question. So we would probably present at the time that the patient would come into the clinic prior to the PET scan. But if they have a PET scan already, they would still be, eligible to be on the study.
Because what I've learned is that when you have a complex design to explain before the PET scan, then patient is going to get scared.
Gotcha.
Now, assume you allow them to come in after the PET scan, and then you say, now your PET scan is negative, then don't try to explain them about the positive side.
I see. Yeah.
Just say your PET scan is negative. We are going to randomize you to extended versus limited. And
makes
that's the simple question.
Okay.
Then if it is positive, how will you justify that your scan is showing disease and you don't want to take it?
So that's why they would get a targeted lymph node dissection for that, or an extended, dissection. So they would be receiving some sort of lymphadenectomy in that. Even
That's where the patient perception could be, oh, I'm getting under treatment. So think of that, because you have a large sample size. You want to reduce hurdles. I like the negative side. That should enroll easily because your scan is negative. We are trying to figure out maybe you have disease, maybe not. So it's easy sell. But when it is positive, then it becomes difficult.
Sure.
Oh, good.
I really like the idea of this trial. It answers an important question. The challenge is the application and the biases that creep in. And it strikes me that you're going to have a hard time. It was brought up earlier, controlling ADT. And the ADT will effectively bias to the null, right? It will take the higher risk folks, put them on ADT. And I'm almost thinking that you may have to end up with a PSA endpoint. Because if you don't do a PSA endpoint, ADT is going to confound the whole thing.
I would be interested in your thoughts on if we did have a PSA endpoint, would you feel that type of an endpoint would change practice?
It's the thing we've been dealing with for 40 years. It screws up all the prostate cancer studies. And it's either an MFS endpoint or it's a PSA endpoint. The things that are in between, it will just be confounded by ADT. I wish I had a really good answer for you.
It'd have to be a PSA endpoint with a eugonaddle state.
Correct.
Make sure that they're covered.
I think you're really stuck. I mean, does anybody else? I mean, doesn't it because the ADT will differentially be given to the ones that you've done the extended, you have more nodes on.
Right. And the punch trial, which many of us participated in, did have a PSA endpoint. That was their endpoint too. I mean, it's been done before. So. Right.
I think that the difficulty with this in overall is that the question is, you're asking if the question of does the dissection lead to a therapeutic benefit, where I think many of us view it as it's more a diagnostic question, and that the diagnosis leads to added therapy. And that added therapy at an earlier time point, perhaps when the volume is less, could result in an improvement for the patient as far as outcome. And, when you leave it up to interpretation where people have the option of deciding when to do early salvage or to do early salvage or to do adjuvant, you could say we recommend not to do adjuvant, but people are going to do adjuvant. People get nervous. Patients don't like seeing their 3 nodes on their path report. And I would say that perhaps looking at it like that's the question. The question is, are you diagnosing node positive and therefore enhancing therapy, leading to a better outcome? And if you're not going to do that, then why do the node dissection, right? I mean, I tell this to the fellows all the time when we're operating. I'm like, what are you going to do with the results of this? And if it's not going to impact your decision on how you treat the patient, don't do it, because it's probably not therapeutic. It's probably diagnostic and leading to our therapy changes.
But a diagnostic outcome is not going to be acceptable outcome.
No, I'm not saying that. I'm saying that you're diagnosing a positive node, and then therefore you act on that and you do the next therapy. I mean, I give Anybody with two positive nodes, even if they have an undetectable PSA, as soon as they've recovered their functional recovery, I give them hormones and adjuvant radiation. And that's based off of retrospective data, that's cohort studies, but that's what's available. I mean, that's what we have to go on. And I don't feel comfortable telling a patient, I'm just going to watch you, because I think they actually have a benefit from that treatment.
I've been reading about, I might be wrong, but isn't there differential sensitivity about different types of PSMAs in identifying disease? So how do we control, like this comes up all the time. Recently I read a report, gallium PSMA will identify differentially between Pylarify. So which one, and then the availability close to your institution, how do you control for that?
Yeah, I mean, I think we were going to allow all different types of PSMA tracers in this, but, I think, from my understanding, the data is relatively similar with regards to the sensitivity for the different tracers. It's not so drastically different that it would, in my opinion, bias results towards, one or the other. So that's kind of how we've approached it thus far.
James, and then.
Great. So if we think about this as like, so in breast cancer, right? If you have a sentinel node that's positive, we used to have asked the question whether you then need to do the axillary dissection or whether you give radiation therapy. Another way to think of this is the PET positive lymph node, the prostate version of a sentinel node. You have that positive node, then the randomization would be remove the lymph node and then do adjuvant radiation versus an extended lymph node dissection. All of that followed by adjuvant therapy. I mean, that's a different question.
So you're saying add the secondary therapy into the randomization.
Well, I mean, you're combining the removal of the gross node.
Yeah.
Followed by comprehensive nodal radiation versus an extended pelvic lymph node dissection. And in breast cancer, that question was important enough that thousands of patients went on that study, and now the standard of care is sentinel node dissection followed by radiotherapy. And then the adjuvant therapy is standardized for all with hormone therapy. It's a different question, but it still would define the standard of care in these positive.
Yeah. Good. No.
Yeah.
Oh, changing batteries. I got boxed out by the battery.
So I agree. Well, I know why you're going for the metastasis-free survival, the survival endpoint, but I think the biochemical recurrence-free survival is probably more objective and free from any problems with adjuvant therapy. You can always leave the overall survival or metastasis survival as a secondary endpoint.
Yeah.
And just a question about the node dissection. Are you defining the template that needs to be dissected? If that node positive on PSMA is outside of the template, just adjacent or common iliacs, a little bit above, are we still going after that specific solitary imaging, or
It's a good question. Probably if it's like a perirectal node or something like that, you probably wouldn't be able to go after it. And so we'd have to define that. And ideally, like you're saying, we'd define kind of the areas that we would dissect, and then ideally perform some sort of video surgical review to make sure everybody's sticking to that template. But you're right. Yeah, we can't, have, surgeons going after all these different, DITSLs. Yeah. So those patients have to be excluded.
because the perirectal nodes is
So yeah,
is one of the issues there.
Right.
I mean, we're learning so much about
Yep.
about lymph nodal drainage or sentinel nodes. I mean, these perirectal, presacral, and solitary things, they wouldn't be counted as a template or within the template.
Right.
Yeah.
Okay.
Got batteries.
I love some version of this. I'm not sure which version I love, but I'd love to see us do this because it's a surgical trial. I'm wondering if I think when we discussed this the very first time, Dan, you said it's complicated. And I'm wondering if there's a way to simplify this and at the risk of we're doing two stages. The first would be sort of a randomized phase 2 or 2 cohorts that you've described there, and maybe just look at a undetectable PSA endpoint 6 weeks after surgery. The reason I bring that up is would that give you a readout on the benefit of the node dissection?
Absolutely.
And also the lack of benefit of, say, not doing a node dissection.
Right. I think you could easily do the left side of this trial pretty easily with a PSA endpoint. And it'd be pretty easy to accrue and do rather rapidly. And it would still answer a question that I think is relevant. And then we could potentially, and then potentially go back and,
I'd like
go
both.
through
I like
other cohort
kind
as
of
well.
the cohort A, cohort B.
Yeah.
You can decide if you want to randomize within both of those or make them single arm. I don't know what the right way to do that is. That design would work if you then say, well, okay, then we're going to establish some sort of standard of care, and then we're going to figure out how to then layer on adjuvant therapy and an MFS endpoint or something like that. But if you just sort of figure out a way to keep it clean, and then what would be my next experiment? What would be the trial, the definitive trial that I would do on the basis of that? Could probably get this done in a reasonable period of time. Just a thought.
So these are all really great comments, exactly the kind of stuff we want. Now you can go back and take those comments with you, and we can talk about it more on our Friday call, the first Friday of the month. Anyone is welcome to join who's interested in helping us with these types of concepts. Before we end our prostate session, I just wanted to give a moment for our patient advocate or for our DEI liaison. Any input on any of the upcoming trials or possible trials?
Tony.
Yeah. Sorry, Karen just stepped away, but no, from what we review, when we get into the discussion of DEI, I like to see them a little bit further along in the development. Obviously, we need to look at things in the front end of the trial for development, but some of the challenges are always the same. When I look at inclusion, I look at diversity, I look also at availability and accessibility. And many surgical trials still require insurance and that the patient has the surgery paid for right out from the gate. So, that's going to limit some of the participation in those cases.
Great, thank you. We have done well with diversity on S1802, and that's, but I hear your point of that being something that we want to bring into our discussions early on. What's our plan? How are we going to be watching to make sure our trials are inclusive?
It's going to be a benefit.
I was going to say similarly, if we plan ahead when we're designing it with the inclusion exclusion and where you're opening, that makes it a lot easier than trying to do it after it's already open. So feel free to involve me when you're designing it and I can kind of help with that. And then for this PSMA PET one in particular, I think the availability of PSMA PETs and then how you're going to pay for the subsequent ones if they're not covered by insurance is certainly something to think about, because for example, our veterans don't have easy access to the PSMA PETs. So making sure we figure that out.
Great, that's great feedback.
Perfect.
All right.
All right, turning it over.
Thank you, everyone.
So Trevor, if you could come up, we'll load your talk.
You guys got two flash drives.
Everyone, is this working? There we go. Welcome, everyone. So my co-chairs and I decided for this meeting that we would invite two of our industry partners to present some of the opportunities that they provided us for doing CLIA level TM in our trials. So the first talk is going to be from Tempus, who I'm sure you're all familiar with. They are working with Seth and Josh very actively in the CTP subtype trial that you heard introduced today during the plenary session. And then Trevor Levin from Convergent Genomics will be presenting his platform, which is a urine-based tumor DNA platform that has already been applied to the urine collected in S1605. That's Peter Black's atezolizumab trial. And Josh Meeks and colleagues were successful in getting their LOI accepted by SWOG leadership to be put forward for a BIQ application in May. So the other one that was put forward was from S1806, this is an NRG-led study to look at subcellular localization of MRE11 as a biomarker for radiation sensitivity. That too was selected by leadership to go forward as a BIQ application. So we have 2 applications under consideration. Parenthetically, we're also having discussions with other companies. So for Everest, there's an active negotiation going on now with Veracyte. You heard about the Decipher test earlier for the prostate trial. There's interest in looking at a similar approach, biomarker approach in Everest, and also Seth in S1011. And again, the Everest trial are talking with our Terra about the possibility of doing digital pathology on the H&E sections that have been collected from those. We have a lot to do to get manuscripts submitted in advance of the upcoming competitive grant submission. I've had conversations with Betsy Plimak's group. Dan Geinesman there is writing up the study where they're combining the Coxon data, S1314, DNA damage repair mutation work, with Betsy's Retain-1 trial. So those will be combined into the same manuscript, and that's under construction. And Jonathan Rosenberg and Gopa Iyer are writing a separate manuscript looking at DDR mutations, looking at the MSK impact platform. So those of you involved in these studies, stay tuned. You'll be seeing some manuscripts soon for review. So, and finally, Bishoy Faltis, we understand, is also working on a manuscript looking at the digital pathology in that same trial. So without further ado, my goal is to have the Tempus presentation, the Convergent presentation, and then Suchi, who's been working hard on a ctDNA protocol, will give us a quick overview of that study applied to 1216. So without further ado, Calvin, take away.
Yeah, thank you very much. I apologize that there's always you can never plan 100% of everything going right with files and things. And so the actual presentation I was going to give you was corrupted. So what I'm going to show you are some slides that are selected from the omics presentation that I gave on the first day. If you already were there, I apologize for any repetition, but I think it'll be a nice opportunity to overview really what Tempus offers. I really think that when you think about Tempus, you probably know what's best for our molecular sequencing, but frankly, it's probably more apt to think about Tempus as a technology-based company, a database company using artificial intelligence, machine learning methods that happens to do a lot of molecular testing, not just sequencing, but a whole battery of various multi-omics tests. And we really have reached a kind of a tipping point, if you will, of reaching critical mass of the amount of data that we've accumulated now through all the sequencing that we've done and the clinical data that we've aggregated, as well as additional imaging data. I think that the molecular data, of course, is at the heart of all of the personalized medicine that we've had in the past decade or two. And we do a lot of DNA and RNA sequencing. But really, I think the richest data has come from the fact that in conjunction with that, we've collected clinical data that has been de-identified and structured. This data is actually collected through physicians sequencing. We are inviting physicians to submit a lot of the progress notes and ideally electronic medical record integrations, but even paper notes that can be imaged. We used optical character recognition, and we used machine natural language processing, but also have human intervention. There's a group of about 300 plus individuals that do this data abstraction, oversee all the quality. And I think this is what allows us to characterize patients very well with time on therapy, with understanding what point they are in the care process, and really contextualizes all of the data that we see. The imaging data includes pathology data. So all of the tissue that we've sequenced has been imaged and is stored in the cloud for further analysis and as a rich source of further algorithm development. And the the radiologic information is actually from an acquisition that Tempus had, a company called Arteris that had been in business for 8 years. This company had actually done a lot of work in lung cancer and breast cancer, and in also characterizing CNS lesions. But I think importantly, there is also an algorithm for RECIST criteria, a digitized automated way to calculate RECIST. This is actually a technology that is installed at over 300 centers in the United States and Europe. And so they've been able to really operate in many radiology departments, helping to improve efficiency and accuracy of the reads. But I think what's important to study groups is really the opportunity to, and we would love to have the opportunity to validate this algorithm in a clinical trial to see not only how these compare with the radiologist read interpretations of RECIST, but also the opportunity to see what clinical value it brings in terms of predicting outcomes. All of this data has actually been helping to improve clinical decision-making for physicians. It has also been helping pharmaceutical companies. We partner with well over 160 small to medium-sized biopharmas, and almost all of the major large pharma companies we do have ongoing partnerships with. This has really been helping with a lot of drug discovery, as well as phase 1, 2, and 3 support through the data that we have and through the testing capabilities. Excuse me. So one of the things I do want to have my colleague show you shortly is a tool called Lens, which is a software, a window into all of the data that we have. So if you are participating with us, you actually can get access to this. And many of the sites that have signed an agreement with us called Tempus Plus, all of the researchers at those institutions can have access to this data, which is really a tool to help hypothesis generating questions. As you're designing a clinical trial, I mean, some of the things that you've talked about here, understanding, should you have this inclusion criteria or exclusion criteria or not? What does a control group look like in real world circumstances? These are very valuable data that can help you characterize these patient populations and understand how you might expect your particular trials to fare. And this is, again, something so helpful that many of our pharmaceutical partners have worked with us on. We now have over 6 million patients clinically with data in this database, and over 700,000 with molecular information and clinical information. And so I do also want to make mention that fact that there are research use only test platforms, as well as the standard sequencing platforms that we offer. The RUO testing includes custom NGS workflows that we can work with you on, both DNA and RNA, methylomics, microbiome capabilities, and genotyping, including GWAS capabilities. Importantly, just last month, we achieved an FDA PMA approval for 2 indications in colorectal cancer, allowing us to offer a CDX companion diagnostic capability. That is something that represents our ability to partner really through the whole range of early to late phase development, and even support for pharmaceutical development for CDX purposes. And so our main testing platforms are here. The XT is our solid tumor DNA panel, targeted panel of 648 genes. It includes a full transcriptome RNA that has been very helpful to help power some of the individual algorithms that you see down at the bottom, including things like homologous recombination deficiency, tumor of unknown origin. These are RNA-based algorithms. We also conduct the sequencing with a matched normal sample of blood, and this allows us to do a tumor normal matched assessment where we subtract out the influences of the germline and allow us to have a more accurate somatic read of the gene mutations there. And it also helps power some of the pharmacogenomic information that you see, such as DPYD and the UGT1A1. The XF plasma ctDNA test is a liquid biopsy capability that includes the immune biomarkers, and for the larger panel of the 523 genes for research use, it includes a blood-based TMB capability. We also have an XG plus hereditary cancer panel that allows us to conduct germline testing when that is indicated. And it's nice to have all of this on the same platform so that the data is all in one place. And then finally, the whole exome sequencing is done on tissue, very similar to the XT, but of course, whole exome comes with the full transcriptome RNA, immune biomarkers, and the incidental germline tumor normal match. So I think I'll just skip over the rest of this. I'll make mention that we have made a lot of investments into our ability to assess genetic ancestry in patients, again, using the germline information. I think this has been very helpful to help characterize all patients, because we often find that racial or ethnic information is missing from the clinical records. And so for many of these patients, we can impute the racial or ethnic identity of patients, or what mix they have. And we've done some work to characterize TMB. We see that TMB is actually very importantly influenced by the germline information, and may be different across different racial groups accordingly. So I think what I'll do is I'd like to actually have my colleague show you a little bit about the lens. I'll make mention here that we have digital pathology capabilities. As I said earlier, one of the very novel applications here has been our ability to assess the presence or absence of molecular markers based on the pathology imaging of an H&E. It is not meant to be a substitute for the molecular test, but rather a screening test that can be running on the pathology images to help hone in on those samples that have a higher likelihood of a relatively rare biomarker, such as MSI high in prostate cancer, perhaps in 2 to 3% of patients. We can perhaps focus in on some of those high probability samples, and the lower probability samples have a much, much lower likelihood of having MSI high. That's just an example. And we've done other things such as TILs and other analyses using digital methods. The radiomic capabilities has been very exciting. This is something that, as I said, has already been operating at a number of centers. We have FDA cleared AI-enabled applications in lung AI, breast AI. We have a cardiology application and a neuro application. And I think excitingly, we have developed this RESIST criteria capability that we would like to collaborate with study groups on in validating the clinical outcomes and advantages of having a digitized automated way to assess these lesions as one progresses on different scans over time. This is something that we think will probably have great advantages in improving accuracy, and that perhaps may actually improve our ability to correlate with clinical outcomes, but it requires collaboration with study groups like yours. We are also assessing a variety of different applications of radiomics at different points in the care process. In this example, it's lung cancer, but it's looking at automated detection of lung nodules and the probability of malignancy to support kind of biopsy or waiting on to repeat the scan at a future time point. Staging on an automated basis so that we can kind of do a better job of that. And then also RESIST criteria, as I said earlier. So really at the end of the day, I think that having the multitude of all of these capabilities, I think when we talk about precision medicine, we often talk in terms of molecular characterizing of patients, and that's important, but also the additional streams of data that we have, the clinical data, the imaging data, including pathology, radiology. I think all of this becomes important, and we really look forward to opportunities to collaborate with SWOG and study groups. And so I'll stop there, but I would like to actually see if I might ask my colleague to just give you a glimpse of what the this lens data looks like. And so I'll ask Emily Teslow, medical science liaison on my team, to give you a quick glimpse of that. And I apologize, because this was not the GU slides I intended. We have an example, but it's a breast cancer example. So please pardon that. Thank you.
Thank you. Hi, I'm Emily Tesla. I'm one of our senior medical science liaisons. What I was going to show you today was an example of stage 4 prostate cancer patients that had either somatic or germline HRR mutations, but that's okay. We're going to show you some breast cancer patients and just give you an idea of the type of real world data we actually have in our database and how it can be used in different ways when you're thinking about developing clinical trials or maybe even analysis afterwards, secondary analysis. So the example here that we have is stage 4 breast cancer patients that have received either palbociclib, abemaciclib, or ribociclib, so CDK4/6 inhibitors. And these patients, based on Tempus testing, have an ESR1 pathogenic mutation. And so this is kind of the way that it looks in our interface to be able to access our real world data and filter down patients that are of interest. We also have lots of different filters that are related to things like Gleason score or PSA score that are in there that you can filter further based on different primary diagnosis. And I just want to mention, this is all based on the clinical data that we structure either manually or in an automated fashion. So once you kind of filter down to a cohort, you can see the cohort characteristics. I've just kind of snapshotted here some of the characteristics that we have. It's pretty extensive, but some of the clinical data that we characterize is things like race or even ethnicity, age of diagnosis, and or the regimen or treatment that they've received. And the treatment information that we have can be very detailed or very broad. We have information about whether or not it was an immunotherapy, a PARP inhibitor, or we get really granular and we can look at the actual regimen that they received. You can see here some of the examples of patients who received letrozole and palbociclib or fulvestrant and palbociclib. And then in the bottom panel, you can see some of the molecular data that we collect. This is either IHC or molecular testing that has been done at Tempus. And so you can see some of the frequency of germline variants in the population, as well as some of the somatic variants. And we also, because we have a lot of molecular integrations with EMR systems at different hospitals, we can also get information about the individual patient records when it comes to molecular tests that have been done either within their institute, in their labs, or even at other commercial labs. And so all of that information is collated for individual patient records. And then I think a really important example of some of the rich data that we have on treatment is in our time on treatment data and time on treatment analysis. And so you can see across patients who had different treatment regimens, what the average time on treatment based on real world data was. So for example, in this treatment regimen, these patients on average had 12 months time on treatment. And if you want to look specifically at individual patients, you can go down to the individual patient level data. And of course, this is de-identified data, so we list our patients based on letters. So for example, a patient I in this particular cohort, they had a treatment history listed here, and you can see different procedures that they might have had, or also different therapeutic regimens, what time after diagnosis they received these types of regimens, interventions, or therapies, how long they were on them, and then any outcomes or details that are associated with it. And again, it's real world data, so we only have this information for patients if it's provided to us in things like progress notes, pathology reports, and through integrations. And then you can look at an individual patient level on the molecular characteristics of that patient and any somatic variants or germline variants that were reported, as well as things like TMB and MSI. And you can see the type of test that they received, whether that was tissue or liquid biopsy, because we do have both of those in our database, along with things like whole exome sequencing as well. And so that is time on treatment. The next thing that's really exciting that we've been looking at is survival analysis. So in the LENS tool, we can actually look at a specific cohort and start to stratify patients by things like variant gene mutations. We can look at survival based on race, ethnicity, or gender, and get an idea of the population and what survival looks like. Because we have really great death data, we're able to do things like overall survival. And this tool is constantly being developed and changed, so the way that we either anchor patients or stratify patients constantly is updated and more advanced. And then this is more of a breast cancer example, so I might skip through this, but this is just an example of how we use our real world data. We partner with many different sites. This was a poster that we presented last year at SABCS, where we partner with different institutes like UPMC, UCLA for this study. And we can use our real world data to look at mutations that are present in patients after therapy. So this was an example of metastatic breast cancer patients who'd received at least greater than 6 months of CDK4/6 inhibitor treatment. That was our criteria for pulling the patients in our database. And then we were looking at the frequency of co-mutations across the different CDK4/6 inhibitors to see if there were mutations that were more frequent based on treatment. And we did find some trends that were interesting in this presented data. So I think I'll end there. Yeah.
Thank you, Emily. And we also did a similar study in prostate cancer that was presented at ASCO GU. We compared metastatic castrate-resistant prostate cancer patients who comparing liquid biopsy versus metastatic tissue biopsy versus the primary sampling of the original prostate cancer. So that was very interesting. Of course, wasn't 100% concordant, but we looked specifically for the BRCA1, BRCA2 ATM genes for potential PARP inhibitor indications. But it was reasonably concordant, about on the order of 70%. I think there was greatest concordance between the liquid and the metastatic tissue biopsy, and less concordance with that original primary. But that's just an example of something that we did, pretty much, with this LENS tool and with an analyst. And I think that's an example of the kind of hypothesis generating observations that you can do. And there's really something that I think, depending on your interest level, almost anything you do, as long as it's in metastatic disease, we're likely to have adequate numbers of patients with samples and data. So I'll stop there and ask if there's any questions.
Thank you. Does anybody have any questions? We can also save them for the end too.
This is just fascinating. I'm wondering, do you have in the data that you collect information regarding measures of access, like insurance and rural access and those sorts of things that can be real barriers to being able to get the high quality versus, are those data there?
Well, I think for the data that we allow in LENS and for research, we do not include insurance data. We don't include zip codes. I think because this is de-identified. However, we do have this data. Yes, obviously we are a lab provider, and we do have that data, but it's just not as a part of this module. But if you're interested in understanding health disparities, that's something that we could do with that information, but it would probably be.
Have you done that yet?
We have not done that.
Okay.
No.
It's just very much of an interest in the organization, and obviously at the NCI levels, that would be
But related to that, for the hereditary ancestry, you could look at that as one of the measures.
Yes, I think for hereditary ancestry, we are actually debating right now, in fact, internally, should we turn that feature on for all the researchers that have access to LENS? And it's not an easy answer, because we do understand that this is a tool that has to be used very carefully. We're very concerned about investigators potentially using it incorrectly or just simply coming up with erroneous conclusions, and that might be very harmful to have those results publicized even without our knowledge. I think the idea is that we want to make all of this data available to the researchers of the world. I mean, that's really our CEO's intent, our founder. We're not interested in kind of, keeping this proprietary, so to speak. But I think we also want responsible use of that information. So I think very likely in the near term, the solution might be that we are assembling a small group of advisors to act as advisors to us that might oversee the use of this information, so that we can say that we've vetted any research that's done with these results through this group of advisors, so that we can feel at least a little more confident that we're not missing something.
Yeah, just a question. This is an amazing data set with 6 million people. Yeah, just wondering, like, when you boil it down to an individual patient, because that's who we see, we're just see individuals. How much data do you need for an individual patient to get you to say, a reasonable certainty at the AUC level of about 0.75 or so, with a reasonable confidence interval for that individual patient? What kind of data do you need, and how much?
I think that when it comes to managing individual patients, again, we've pretty much made this data available for research in general. I think we've stopped short of really offering this tool as an individual patient treatment tool, only because I think, again, it's very easy to make mistakes in individual researchers. I mean, even as we do these projects, we recognize that, as we come back to a particular inquiry that we did, we think of something, oh, wow, we have to understand how this data was collected. What are we looking at, right? What are the caveats? And I think that we are very careful not to use this to guide individual patients. I know that that's obviously a potential future need that we could all aspire towards. But I think that, again, that's why we're very careful just to say this is a hypothesis generating research tool. It could help you design trials. It could help you understand populations in general. But I think I would be careful to use it for individual patient care.
Yeah.
So on an individual patient level, the whole reason we curate this clinical data and it's submitted to us is actually to make the individual patient report smarter. Essentially, it helps us understand what they've received previously and what they would match to based on current NCCN guidelines and OncoKB type information. And so that's kind of how we're using the data right now on an individual patient level. So the more data we have in for a patient, clinical, molecular, et cetera, the smarter we can make the individual patient report so that it's easier to interpret.
So have you gone back, with those individual reports and looked at what data were used? So okay, well, I need, this blood work, these x-rays, this genomic information.
Yeah, I think this is a good point. So the smart reporting that we're talking about here is more about the assigning of information on the report that would really grab pieces of a clinical information that might contextualize that particular report. So, for example, many times patients are matched to clinical trials. We wouldn't want to match a patient to a clinical trial for a drug they've already taken, or for if they have an exclusion criteria for that particular trial. So those are some examples of personalizing that patient report. I think that I suspect what you're talking about, something that's even much farther down, where you're talking about rarer patients and treatments and what can be offered. I think that that's something that, again, I mean, a physician could use this for that purpose, but it's not something that we would actually stand behind in a report.
Right.
Right.
No, I just kind of want, because I mean, it's an amazing set. And maybe some patients where the genomic data are extremely helpful, and other cases where they're completely useless, and it's image and lab based that drives the decision. And so I had wondered about that, but yeah, I guess that's for a future study. But also, have you done any like validation, like say with new data that are coming in? Because you're getting new data all the time. I mean, you could do an independent validation on a prior model and you can give us a readout. Have you done that with some of the data?
Well, we do, all of the algorithms that we've built so far and all the ones we're continuing to work on are exactly examples of that, where we're, going into our data to kind of see, can we come up with models to predict a particular outcome using our database and its outcomes. But I think we're also very clear that when something is done in this way, it's still hypothesis generating, and we're very careful about any claims we make. We recognize that there's no substitute for the proper clinical validation study, clinical trials, controlled patients cohorts, and so I think that we really hesitate to say something can be ready for broad clinical use with that kind of clinical validation evidence. It's there for physicians if they want that, but we're just careful about how we position it.
Yeah, it's a lot of times we'll do, short of having the data, we'll do validation on a new data set. It's pretty common, or leave one out.
Right.
It's a great discussion. I think for the sake of time, we've better move on to the next talk. But thanks very much, and again, a great opportunity for potential collaboration.
Thank you for having us.
Sure. So, Trevor?
I wonder, while they're pulling the slides up there, Dave, we've had this really interesting conversation on some of our TM calls around collaborations with groups like Tempest or Atera and so forth. And it's just around this issue of, what level of discovery we can actually do, within SWOG cohorts. And I think many of us are of the mindset that maybe, we can actually start working with groups like this to do a bit of discovery work, particularly when it involves sort of non-exhaustible tissue resources, like things like, photo scans of slides and what have you. So I think this talk is actually very timely and sort of coincides with a lot of stuff we've been talking about online.
I'm glad you said that. I think also with interest in robust measurements, these companies have done a lot of homework to get these measurements robust, and so it's probably worthwhile for us to really think about what we want out of these relationships.
Sometimes it's just a little finicky.
Okay, great. Now I can see it. It's great. Okay. Pardon the interruption. So pleasure to introduce Trevor Levin. Trevor has been working with us for quite a while, actually. Teresa Kopi was one of the people who connected us to Convergent way back in the day. And as I mentioned, they're working with us on urine from urothelial cancer studies. Hopefully we'll see the day someday when we can see similar things in urine from patients' renal cell carcinoma and prostate trials. But Trevor, take it away.
Thank you for inviting me, David. So we really started Convergent back in 2015. We spun out of Oregon Health Science University after working very closely with the urology department there, but also Dr. Joe Gray, who invented fluorescence in situ hybridization. And he felt like it was the time for new advances in next-gen sequencing to provide richer
Good sign.
That's a good sign. All right. I'll trust you on that. So it was time, for new advances in technology. And so we left the university, and really with the support of the National Cancer Institute through Small Business Innovation Research grants, we bootstrapped the company. But now we're a CLIA certified and CAP registered lab. Didn't travel too far today because we're actually here in South San Francisco on the kind of biotech capital of the West Coast, right next to Genentech's campus. So I'm going to talk to you today about a urine liquid biopsy that we've been developing in non-muscle or for non-muscle invasive bladder cancer. There are challenges and opportunities, and I don't have to remind the room here that recurrence rate is quite high. But to just put it in context, this is one of the highest recurrence rates of all cancers. And so we have some amazingly talented surgeons here, yet the biology is really challenging. Advances by this group here with post-op chemo, BCG maintenance, enhanced surgical methods, they're making progress, but the biology is still complex. We have challenges like genomic field defects in the bladder, multifocal disease, and these non-papillary tumor shoulders or carcinoma in situ in the bladder that can be really challenging to visualize cystoscopically. But I'm very optimistic about the new therapies that SWOG and others are putting forward into this space, because I think this is really the solution to help improve the rate of recurrence for these patients and to minimize disease progression. The one other piece of background I want to provide, just as somebody who loves new technology and genomics, is to remind the audience here that the cost of sequencing over the last, since the human genome sequence took 10 years, $1 billion. That was in our lifetime. And now today, you can sequence a human genome in a matter of a couple days for less than $500. And that's advancing faster than the changing in compute power that put these cell phones and computers into our pocket. And so within our lifetime, again, we're going to see this technology become so accessible that really we can stop thinking about cost so much as a barrier. And the next barrier becomes information. How do we figure out how to use this? How do we make it actionable? And so one of the ways that this information is being made useful today is through comprehensive genomic profiling of generally later stage tumors and minimal residual disease testing. But with this reduction in cost and the accessibility of this technology, imagine the potential of prognosis in earlier stage cancers to identify those patients that will progress, or in non-muscle invasive bladder cancer, as these therapies, some expensive gene therapies and immunotherapies are moving into this space, we need to target and focus those towards the right patients, and seriesing drugs as well. So there's a lot of information that can come from this. There are a couple different ways of doing MRD and minimal residual disease testing, and I'll highlight a couple of them. There's tumor-informed, where you take the primary tumor tissue, you sequence it, and then you follow a group of those mutations in blood or urine. There's also a non-tumor informed or tumor naive approach that one can take. It's a little more challenging, frankly, because there's an amazing amount of complexity in the mutations that exist in blood samples and in urine samples. But there are reasons to do this. So there are logistical challenges for tissue access. Oftentimes biopsies may not be large enough for analysis, for molecular analysis. Many of you in the audience, you're working at tertiary referral centers where the sample may have originally been cut out in the community somewhere, and just getting a hold of that tissue can be really challenging. In bladder cancer, though, in particular, thinking about the really high recurrence rate and this multifocal disease, is it the right tumor to be looking at, even something that was cut out many months ago? So tumor evolution, response to therapy, surgery puts an amazing amount of pressure, removing some mutations, leaving others behind. The immune response of BCG also promotes evolution of the genomics of these lesions. So you're playing this game of whack-a-mole, and the tumor is constantly evolving, and you want to be able to monitor and track this, is the idea. So that's one reason, or another reason, to use tumor-naive MRD. And also just the benefit of mining the defective field of cancerization in the bladder, and that these recurrences can happen sometimes years after initial treatment or diagnosis, as well as progression. And so watching that defective field with a kind of broader lens can actually be quite useful if we learn how to interpret it. Now, in taking this tumor-naive approach, what we actually do when we measure a urine sample or a blood sample looks a lot more like a comprehensive genomic profile that you would think of typically achieving in a later stage cancer patient. We currently have FDA-approved cancers and companion diagnostics in just 31 genes today, but there are many more under investigation, and it's evolving rapidly, an area of great promise. So as we set out to develop a tumor-naive MRD and comprehensive genomic profiling test, we stood upon the shoulders of giants, many of you in the room here that pioneered massive genomic data sets with the Cancer Genome Atlas, as well as the CBio portal that made so much of this data really accessible for all of us, we identified some of the most important and informative regions of the genome to do ultra deep sequencing on. The advances, of course, in NGS allowed us to do this with exceptionally high accuracy, so that we can find that needle in the haystack, the 1 in 1,000 mutation that's surrounded by other normal cells or immune cells. Pairing that with large clinical trials and the latest advanced machine learning and AI as well, to help understand what do these genomic profiles really look like when a tumor is present or in a surveillance monitoring patient. So this is what EuroAMP does under the hood. And it develops a rich set of data that gives us these biologic insights and ultimately working to translate them now into clinical impact. When we measure a urine sample, we make 15 billion DNA-based measurements on every single sample. So that quickly became a data problem. Half of our team in the lab is actually dry lab. They're data scientists. So 15 billion DNA measurements, 60 genes are deeply sequenced, but then we also sequence the whole genome in a shallow fashion to look at large scale changes like aneuploidy or large scale rearrangements that can happen in the genome. We take this information out of those 60 deeply sequenced genes and the whole genome, and we categorize them into 6 classes of cancer mutations. These are things like single nucleotide variants, microsatellite instability, copy number variation, aneuploidy, and then apply algorithms to this as a rich data set. And from that, we get some really interesting biologic insights. We can track mutations over time, a kind of longitudinal genomic disease burden or an MRD disease burden, tumor heterogeneity and clonality. In response to therapy and BCG, we've seen some very interesting things. Interpreting these genes in terms of pathways, but also applying algorithms and correlating some of these genes are much more enriched in muscle invasive cancer, for example, or in invasive tumors, or in high-grade tumors compared to low-grade tumors. So we're able to grade and to help provide some auxiliary information that may augment standard pathological staging as well. So this allows us to look at urothelial cancer and cancer in general in a very new way. When we sequence the urine from otherwise healthy controls or smokers or people with blood in their urine, we start to see things like early bladder clonal development that's associated with age or carcinogen exposure. But you can almost start to see by eye these changes in the genomic profiles where you say, this doesn't look normal anymore. This doesn't look like just an age associated field defect. You've hit a growth receptor tyrosine kinase. You've lost genome integrity. And when all of these pathways start to come together, it kind of starts to look like something like a malignant dysplasia or some early clone. We see these changes happen when a tumor is not yet visible, but we see them correlate with things like recurrence. And then we also train the algorithms to understand what is most likely to be a cystoscopically visible tumor. We've also studied tumor and urine together and these tumor urine correlation analyses. So one of the takeaways from our first published paper in Journal of Clinical Medicine was that when you look at urine that's collected prior to a TURBT, surgical resection, 90% of those mutations on average can be found in the urine specimen. But there's also 50% more mutations in the urine that are not seen in the primary tumor. And it's not uniform though across all patients. In this example of a urine and tumor correlation from that paper, a surgery was performed. 13 days later, we got another urine sample, and that individual's bladder and the urine was squeaky clean. There were no mutations left. There are other cases where there are lots of mutations left, and these do tend to portend future recurrence. And I'll share data with you on that as well. So when a sample comes into the lab, I'll just explain briefly what happens so you can understand the process. We spent a couple of years developing sample collection kits, actually, before we developed the CLIA lab, just to handle a urine specimen so that it's stable up to 2 weeks at room temperature. We wanted to really make sure that this was a practical test, that it didn't require timed urine void, for example. We worked to stabilize urine at random voids throughout the day to enhance nucleic acid extraction so that we could get enough DNA and RNA out of a urine sample regardless of when that sample was collected, regardless of hydration status of the individual. So a urine sample collected at point of care, very common in the urology clinic. We have the preservative buffer here in a vacutainer, and just aspirate the urine into that vacutainer using this Benton Dickinson cup. It's then stable for the next couple of weeks. It's transported by FedEx ClinPack into the lab. We perform nucleic acid extraction. All of our processes over the last couple of years have been automated onto robots for very high efficiency and to minimize sample handling error. We then go through a series of molecular biology reactions. This is called library preparation and target enrichment to focus on those 60 genes so that we can interrogate them very deeply as we make those 15 billion measurements. We perform next-gen sequencing, apply the data to the cloud and a layer of machine learning algorithms, and clinical reporting. And this is an example of a report and what a report looks like. This is a patient on the bottom. So this patient in particular, they had molecular features that were associated with a high-grade cancer based on the urine specimen, and they were a high risk of recurrence. So their 12-month recurrence based on the genomic profile is estimated to be around 28%. On the bottom here, you can see the MRD profiles. So this is a urine sample collected prior to surgery, and their MRD score is 88. This is to say they're in the 88th percentile of all previously analyzed bladder cancer patients. There's a pretty big mutational or genomic disease burden. After TURBT and surgery, the score goes down to 59. It's not completely resolved or removed, but they go on to BCG, and BCG, they show what we call a responder profile. Their score goes down from 59 to 18, but the mutations are still there and persisting. You can ask, perhaps this patient may have benefited from a few more than 6 cycles of induction. Sometimes we see these delayed responders where you see the response starts happening in the 4th or 5th cycle, but not until, but then you stop at 6. And why 6 for that patient? Perhaps they would benefit from more. And then for this patient, the genomic disease burden came back up at time of negative cystoscopy, and then a recurrence was detected a few months later. So with that, I'll share with you some of the early data and studies that we're developing. So one of the first tasks that we set out to do was to just understand how this genomic information can classify disease as present or absent. And for this first study, we looked at individuals who had primary tumor diagnosis compared to subjects with blood in their urine. We trained an algorithm on 195 samples. We got a sensitivity of 98%, a specificity of 96%. And then in partnership with Adam Feldman and Kian Solari at Massachusetts General Hospital, they had an independent bank of urine samples. They gave us the samples, they blinded us, and we returned results back to them. We were correctly able to classify 96% of the tumors as tumor positive and 90% of the control, the hematuria controls, as controls. Now, one futuristic application of genomics may be in this initial diagnosis setting. Imagine that the genomics and the sequencing really is $50 to get it run. You might every few years, or if you have blood in your urine, monitor your somatic genome in your bladder. And the challenge though of this is 90% specificity really good enough with the incidence of bladder cancers in certain patient populations. And so you really have to think about clinical risk groups. And the AUA has done a really nice job with their updated guidelines of defining the prevalence and using microscopic hematuria and smoking history to create these risk groups. You have pretest probabilities anywhere from 0.5 to 10%. And you can think about this type of performance, specifically the 96% sensitivity and 90% specificity in terms of diagnostic likelihood ratios, where you can roughly, I'm not a statistician, I'm a biologist, but you can kind of think of this ratio as something that you can roughly multiply by the pretest probability. And so with this performance, you can take a low risk patient who has only a 0.5% odds of having bladder cancer based on the level of microscopic hematuria and smoking history. And if they have a positive UroAmp about 4.5% of them will have a tumor found on cystoscopy. Maybe, a little more interesting, maybe challenging to decide whether these lower intermediate risk groups of patients receive a cystoscopy. 1% pre-test probability will lead to almost 9% odds of cystoscopy. On the negative diagnostic likelihood ratio, you can, with the same group of people, you can take the odds down to really low. 0.03% of patients with a pretest probability of 0.5% would have a positive cystoscopy. Now, obviously, we need larger studies to truly enable this. And we're going to need FDA approval and evolution in Medicare and insurance companies' reimbursement strategies to really allow genomics to do this. But what's encouraging to me is that when we look at this level of performance, it tells us that it's certainly better than cytology, it's better than Eurovision FISH, and it is showing some significant performance and improvement benefits over traditional biomarkers like gene expression or immunoset protein biomarkers.
Is that a binary outcome? It's a binary positive, negative, or zero grade?
Yeah, this is simply a binary, positive or negative. That's the other, we did the comparison to cytology. We have a paper, this data, it's under review and it should be, hopefully, I'm knocking on wood, in press very soon at Clinical Cancer Research. And when you compare to cytology, you have to carve out the indeterminate or atypical group. So I present this kind of as background to now think about MRD. And we took the same type of algorithm where we used these same mutation features, but we also trained it in surveillance monitoring, looking at recurrent tumors relative to surveillance negative cystoscopies. And we applied this algorithm. So now thinking about this 90% specificity, these false positives, where the algorithm believes that there should be something visibly apparent by cystoscopy. And we're studying this now in a group of surveillance monitoring patients. This is a group of 120 subjects. Everybody comes in at time of negative cystoscopy. So the study enrollment is prior history of bladder cancer, negative cystoscopy today on the day of urine collection. And if the algorithm believes that this looks more like a recurrent tumor, should be cystoscopy positive, that's a high-risk patient. And this is now going out to 36 months. The recurrence-free survival in that patient group is about 45%. If the algorithm believes that this is likely a surveillance negative, it agrees with the clinical status, really, of the label at the day of entry into the study. There was no recurrence observed in that cohort of patients until beyond 12 months out into the future. These low-risk patients tend to more likely have low-grade recurrences as well. We had a couple interesting anecdotes in this cohort as well of progression, where we were classifying patients with a history of low-grade TA on once per year surveillance regimen at Massachusetts General Hospital. They had a very screaming signal at that baseline urine collection and on the day of negative cystoscopy. 543 days later, they had a T4A in the prostatic urethra diagnosed. And it's just that future diagnosis 543 days later was much more consistent with the urine sample collected 500 days ago. So with that as a framework now that we can predict recurrences in patients with negative cystoscopies, we applied the same algorithm and set of rules to a patient population, BCG naive, undergoing their very first induction therapy. This was a study that we did in partnership with Gopal Gupta at Loyola University and his very talented uro-oncology fellow, Goran Rak. It was a prospectively designed study, observational, and the very first urine sample that was collected in this study was following surgical resection, TURBT. As an inclusion criteria, all of these patients had to have visually complete TURBT prior to entry into the study for analysis. And this is fascinating to me to just look at the number of mutations that exist in this group of patients. There are subjects on the right side of this plot that have over 20 mutations in their bladder immediately following surgical resection. And there are other patients on the left side of the plot that have almost no mutations. So there's a huge amount of diversity that exists in this BCG induction patient population. We can take these mutations and not only count them, but we can look at the signal intensity of their allele frequencies, like how much of the DNA in the urine is actually associated with these mutations. And we score it on a percentile score and compare it back to other patients that have been historically analyzed during bladder cancer surveillance. And you can see that there's a group of patients up here that are around the 90th percentile. I mean, their genomic signatures look a lot more like somebody with a tumor, a cystoscopically visible tumor, than they do somebody who's just had surgery. And it just shows the challenge of this biology of this disease. Now, when we look at this genomic disease burden score further, those who ultimately developed recurrence in this cohort have a much higher genomic disease burden. The allele frequencies of their mutations are much higher compared to those who did not have recurrence. And this is what it looks like by Kaplan-Meier survival curve analysis. Now, remember, this is the one urine sample collected before they even go on induction BCG. So we're not looking at the impact of therapy yet. This prediction was made at a single time point. So this is the efficacy of surgery, really, to some extent, in whether they're going to respond to the BCG and have recurrence. So if you're in this high-risk group, recurrence-free survival, again, is 45%. So we see a couple different, when we look at the next urine sample after induction therapy, we see different profiles. Subjects that had what looked like very successful surgeries. There's this interesting group of patients that are responders, that respond to the therapy through induction. And there's groups of patients that are refractory and do not respond. And this is generalized over the whole cohort. And in the Kaplan-Meier analysis now, this molecular refractory, I know we're using a clinical term here, but MRD refractory, the rate of recurrence-free survival is less than 20% out at 36 months in this very high-risk group of patients. If you look at the responders, they're still having recurrence, but those who ultimately went on to have recurrence tended to have higher mutational signal intensity prior to induction. So harder for the BCG to get its arms around a larger disease burden at the onset. Now, I want to introduce just briefly, how long do we have? We're a couple minutes. All right. So we'll fly through some data that's very relevant to a study that you guys supported, SWOG 1605. And this was non-muscle invasive, BCG unresponsive patients who underwent atezolizumab. And the analysis that was presented by Peter Black showed that the overall cohort had 29% CR at 18 months, an analysis of 135 patients. Remember this number, 25% CR. It's interesting now when we look at the genomic profiles. Urine samples were collected prior to atezolizumab induction and at cycle 5. And we've analyzed both of these urine samples now. And this is the same type of waterfall plot. Look at the immense genomic diversity that exists within this cohort. There's some subjects on the left side that had very successful surgeries, and on the right side, people that have very significant genomic disease burdens. There are many genes in this cohort that are unique to or distinct from BCG naive surveillance high-grade bladder cancer patients. This cohort has a significant enrichment for ERBB2 and ERBB3, as well as amplification of NIT1. We see these responder profiles over time as well. 15% of the cohort had no notable genomic disease burden at the time that they entered the study. It had very successful surgeries. There are responders, complete MRD responders, that represent about 5% of the cohort. 9% of the cohort showed some partial genomic response. When you add these all together, coincidentally, it's about 29% of the cohort, which is roughly the CR rate at 18 months. And then 70%, the other 70% of the cohort, they were either MRD refractory or they showed active expansion while on therapy. And there's a lot of richness to the genomic data that you can go into further, but just to show that some of these patients, compared to baseline and after cycle 5, they're showing a significant clonal expansion of their disease while on treatment. So a little bit of a cliffhanger for you. I don't have the correlations yet to long-term outcomes. This data is being summarized and will be provided to the SWOG stats committee to look at this MRD response category relative to the long-term outcomes, but excited to support potential analyses of SWOG 1602 and other studies. With that, we're all about collaboration. We've got a tool that we've spent a lot of time validating, very excited to publish papers with the academic community. We can't do this without you. So with that, thank you.
Thanks. So I think we should just have time for 1 or 2 questions, so we leave time for Peter's session. So go ahead.
Hey, Scott Delacroix. On your predictive report that you put out, that's going to be very much based upon the patients that you're comparing the data set that you have, clinical data set that you have. It was only 140 patients, correct? 150 patients on that initial report, like slide number 8 that you showed.
So the comparative analysis that we run right now, we've run 4,000 samples through the development since the assay has been locked. So we're comparing to a larger group of patients.
So with all the different therapies that are coming out, you've got the bridge trial that's coming, you've got Tokyo BCG, you've got TICE BCG. I assume there is a potential that you're going to have to delineate that data set and know what treatment you're planning for your patient to be able to give a prediction. And it may change. If you're going to give Gemdosi, if you're going to give TICE BCG, if you're going to give Tokyo.
So just an
BCG.
editorial comment. To my knowledge, we're not collecting urine in the bridge trial.
Really?
Really?
Okay. Well, that's not a SWOG trial. So 1602, we collected urine. So with 1602 data, you may be able to do or validate like a potential risk calculator for 1,000 patients that have 3 years of maintenance and be able to go back at different time points and validate your data set. This is very interesting. Are you working with Rob and SWOG to do that? Or you're just pitching that right now?
We're in the process of putting together that grant application.
It's been nominated to go forward for a BIQ.
So just a quick question. Does this test apply equally as well to different histologies and micropapillary and some of the variants?
We would love to look at that. Those are still rare in our data set, as you can imagine.
And upper tract tumors too.
Yeah.
Listen, folks, thanks a lot for the presentations. Suchi, I think we're gonna have to wait on yours, so we leave time for Peter's session. So thanks, everyone.
All right. Just a reminder, the cancer control committees, if you have any ideas, always happy to help out. These are the current studies. I was just going to kind of briefly go through those. We actually have Dr. Nappy here today to talk about 1803 and give us an update on that one that we haven't had for a while. So we'll start there.
Thank you, Peter, for the invitation. Thanks, everyone. I'm going to give you some updates about S1823, which is a biomarker validating study in testis cancer patients, early stage disease. So S1823 is a cohort study. It's been activated through SWOG Prevention and Epidemiology Committee. And I am the PI with Dr. Nichols. And it's essentially based on the knowledge that there are clusters of microRNA that are expressed in germ cell tumor, testicular cancer, and we want to see whether or not plasma-based microRNA is able to predict or anticipate tumor relapse in patients with stage 1 or stage 2A germ cell tumor. So this is the study design, very straightforward. We collect blood post-archaectomy in all the patients enrolled, and then serially and longitudinally during the surveillance until they relapse. And we want to see if the microRNA is positive post-archaectomy, or if it's not, when exactly becomes positive to anticipate the relapse. So we had 3 risk groups. The high risk group included patients with metastatic disease has been completed, and we still have the low risk and the moderate risk open. This is the schedule of the blood testing. It's every 6 months for the low risk patients and every 3 months for the moderate risk patients. And the primary endpoint is to establish positive predictive value of microRNA 371 in detecting active germ cell malignancy, and to establish by how much time the microRNA becomes positive. We target 100 relapse in non-seminoma and 50 in seminoma, and the overall number of patients to be accrued is 956. We plan a futility analysis at 40 relapse in each seminoma and non-seminoma group. So we are also planning a lot of secondary use of data for this study. We are looking currently at different pattern of care in testis cancer. We want to compare the outcomes in centralized versus dispersal of care, and we want to analyze microRNA 371 characteristics, not just in gonadal testicular germ cell tumor, but also in ovarian germ cell tumors, and in non-extragonadal, non-gonadal germ cell tumors. So this is a successfully occurring study. It was activated in June 2020, so during the pandemic. And so far we have 716 on May 1st, so it's a little bit higher now of the 956 patients. So we think that we will be able to complete the accrual by next year. This study is open in the United States through the NCORP, and in Canada, in almost all the provinces. I think just the Quebec didn't activate it through the Canadian Cancer Trials Group. So I was asked by the Prevention Epidemiology Committee to put a slide together about why this study has been so successful, considering testicular cancer is not a very common disease and affects a population such as AYA. It's not very easy to enroll in trials. So I put some together. So I think one of the reasons that we haven't had testicular cancer study for many decades. So everyone is excited about doing a testis cancer study. It has been open through the NCORP, so also community care centers have been heavily participating to the study. It's a very simple, straightforward clinical trial. There is not a huge burden of work on the participating sites and also on the patients. So the schedule of surveillance is very flexible. And we try to integrate or coordinate with other groups like SWOG to try not to repeat studies. There is a very high sense of belonging to the testis cancer community, which I think it's it's been very helpful. And then there is an acknowledgement of the high potential clinical impact. And this is my personal opinion. There is not a lot of big egos in testis cancer. So this makes obviously things much easier. And that's my last slides. Thank you very much. Thanks, Peter.
All right, I know we had some update from Dr. Kruder at the microbiome symposium, but she was going to update the rest of us too.
Thank you so much, Peter, for having us. Really appreciate this cross-tumor trial that we can keep highlighting this and help with accrual. this has been a huge team effort, and actually PIs, Dr. Gunturo and actually Dr. Hirschman together. Had focused on the translational aspects of the study together with Dr. Suen Liskoven. Our primary objective is to develop and independently validate a risk prediction model for high-grade immune-related adverse events during the first year of ICI therapy, checkpoint inhibitor therapy in solid tumors. I won't bore you with the secondary objectives because I want to give Brandon, Dr. Garcia, time today because he will actually, he's proposing and approached me to develop together a microbiome project that we find quite exciting that he's trying to add on, including a dietary questionnaire. Wanted to let you know, so this is a real world cohort study and the accrual has been remarkable. Thanks again also as the similar to the previous speaker has told us, thanks to NCORE sites, we also have South America now added on, and it's a real world patient, fairly pragmatic, low intensity, besides some of the translational components that help sites also to increase their NCR accrual, which they appear to appreciate as well. Just briefly, this study schema, again, fairly parsimonious with just a few time points. And here the focus for the translational aspect is at baseline, as well as the first month or at the time of IRAE. Beyond that, it's just PRO assessment and toxicity assessment, essentially. Here's briefly the study calendar. Again, we won't have time to go over that. I'll be happy to answer any questions that you may have. And again, a key part of this is really to develop a biorepository for translational aspects. So when biomarkers and hypotheses come along, we really have a large validation cohort where small hypothesis generating data can be validated that appear interesting. The CyTOX score was one of these early suggestion hypothesis generating data that might really be predictive, and it's an easy ELISA test. But really our excitement is in the tumor and other blood and plasma, as well as whole blood for also germline testing that we have available to collaborate with other investigators. And now we just also have the amendment for the microbiome. So in summary, this is a real world study for solid tumor studying checkpoint inhibitor. We really appreciate your support, and please consider opening this in your trial. We just learned we likely will get the expansion to also the chemo checkpoint inhibitor combinations, which currently were not yet eligible for this trial. So we will likely get a significant expansion of this. So we'll really appreciate if you can participate. And will Brandon be able to present after me? Yes, great. Thank you. And I'll be just, sorry, thank you.
So yeah, as Dr. Kruger mentioned, we had a young investigator, Brandon Garcia, who had some data on a dietary questionnaire and immune therapy. And he is going to present virtually.
Great, thank you. Can you hear me?
Yeah.
Okay. So thanks for letting me present this concept. I'm Brendan Garcia, a medical oncologist at the University of Rochester. Developed this concept with Nicole Kuderer and Peter Van Veldhuizen, and preliminary data for this was generated at Sloan Kettering with my mentors, Gopa Iyer and Joe Lee, supported in part by Beacon. Next slide, please. These are just my disclosures. Next
So we're
slide.
gonna, yeah.
So we can actually skip the background because actually almost the entirety of this background was covered by the microbiome symposium today, very conveniently. So we're just going to skip to my preliminary data. But in short, the microbiomes clearly impacts immunotherapy efficacy, and the microbiome is affected by diet, especially the microbiome of the gut. And given literature in melanoma suggesting that dietary fiber is associated with immunotherapy efficacy due to fiber fermentation, leading to short-chain fatty acid metabolites with immunomodulatory properties, we hypothesized that fiber might be associated with superior immunotherapy efficacy in advanced GU tumors. And so to test that hypothesis as a fellow, I designed with my mentors, Gopa Iyer and Joe Lee, a prospective cohort study where we invited patients with advanced urothelial or renal cell cancer initiating immunotherapy at Sloan Kettering to complete a dietary questionnaire. Next slide. Sorry, next slide.
Yes.
And And so we followed them prospectively for progression-free survival and estimated their fiber intake. And we found that there was a statistically significant association between higher fiber intake and longer progression-free survival among patients with advanced urothelial cancer on immune checkpoint blockade in our multivariable analysis. We also saw a strong trend towards longer PFS among patients with renal cell cancer too. Next slide, please. So while these findings suggest that fiber is associated with immunotherapy efficacy, there's also reason to suspect that fiber might protect against inflammatory and autoimmune effects. Like, for example, fiber is inversely associated with risk of Crohn's disease. It's been shown to reduce airway disease in mice related to allergies, and it's inversely associated with markers of inflammation like IL-6. Next slide. So based on these compelling data, we hypothesized that fiber also reduces incidence of immune-related adverse events for patients on immunotherapy via the gut microbiome. Next slide. And to test that hypothesis, we propose addition of a brief and validated dietary questionnaire to iCheckIt. Next slide. iCheckIt's really an ideal context for dietary analysis because it already includes analysis of the gut microbiome. And it already includes surveys at several time points, so it's very feasible to add a brief dietary questionnaire. Next slide. The questionnaire that we would want to add is the validated NCI Dietary Screening Questionnaire, or DSQ, which is the same dietary instrument that was used in a prior study of fiber in melanoma at MD Anderson. Next slide. And to seamlessly integrate the DSQ, we'd add it to the iCheckIt surveys at baseline and at 4 weeks on treatment, which would coincide with collection of blood and stool collections that are already ongoing. Next slide, please. With the DSQ, we'd aim to test whether dietary fiber is associated with immune-related adverse events, as well as the contents of the gut microbiome and fecal metabolites like short-chain fatty acids, and even with the cytox score, which is a key measure in iCheckIt. And all these variables are already being measured in iCheckIt, except for dietary fiber. Next slide. So for sake of time, I'll actually skip the next couple slides too. But in short, we would use Cox models and Spearman's rank correlation to test our hypotheses. And with regard to sample size, iCheckIt has approximately 1,100 more patients left to accrue. And we would only require 500 for 85% power to detect a hazard ratio for grade 3 immune-related adverse events of 1.5 per standard deviation of dietary fiber intake. And even if recruitment fell short, 440 patients would still give us 80% power to detect the expected effect size. Next slide. We do, of course, also plan to apply for Hope Foundation Seed Award funding to cover any additional effort by SWOG staff, though we expect the burden from this questionnaire to be minimal. Next slide. So I'll keep it brief. Thank you very much. I'll just note that we did also present this concept recently to the Immunotherapy Committee and have already received some very positive feedback. So we're looking forward to getting more feedback as we continue next steps. Thank you.
So you have any comments? We're hoping we can have time enough to get it incorporated into the study.
Just want to echo what, see, does it work? Yeah, I wanted to echo what Brendan has said. The IO committee has been fantastic in the reception of this. And we're still working out some details, but we think it's going to all work out with iCheckIt. There was first question, how will we operationalize it? It will still add a little bit of effort for SWOG staff. So we'll have that final discussion, I think, in 10 days or so. And Brandon has done a phenomenal job also getting the grant written for the seed money as well. So we really are quite excited, but please, any questions?
This is a question from a fellow Rochesterian. Brendan, this is Rick Banks. So the question is the intake for the DSQ, I think that was the survey form. Is that a patient form or a clinician form?
Great question. There actually are different forms of the questionnaire that could be either filled out by the patient or by an interviewer. To fit with the PROs that are already in the study, we were planning on integrate the patient completed form.
Okay, so if the patient completes the form, is there a Spanish version?
There actually is.
Okay, and we're planning to use the Spanish version as well, right?
I think that would be ideal.
I do too.
We will work very hard on that to make that happen.
I was just curious, this is for both Nicole and Ben, and I check it, are you guys collecting response data as well at those time points to IO?
Funny you should say that. That was a key discussion early on, and we were hoping to get that, but Don rightfully discouraged us to do that, just to, again, to keep it pragmatic. I'm hopeful, also learning from Pragmatic and Dr. Redman's study. I don't know what the precedent there is. I suspect because it's such a wonderful, large validation cohort, and response biomarkers would be such a phenomenal way to also have this cohort to be there for validation efforts there as well. I wonder if we could not go back and get at least kind of a real world pragmatic response data. But again, that would require really serious projects and serious money to do that.
Yeah, I think that's probably the more logical build between, fiber intake and, response as opposed to fiber intake and toxicity based on that science paper is maybe a little bit more of a stretch, from my standpoint to link with toxicity, but it's not unreasonable.
Yeah, and Brandon didn't get to discuss some of the short chain fatty acids are really a nice linker between TIDE and the immune response. It's one of the hypotheses that he might be able to also add to this, as we also have the metabolites.
All right, thank you. Thank you. Anything else? All right. Just to briefly go through, thanks, Nicole. Through the other studies, S1600, Jill could not be here, but I think we're all aware of the study. The accrual goal of 200, it's actually at 171. So hopefully we'll get there soon. I don't know that there's any other major issues with this study. The green tea active surveillance study has had some issues with accrual, and they've made some variations to the study to hopefully help address it. Actually, changed, I think, the accrual goal to over 300 to 165. These have actually been approved now. And so hopefully that will continue to accrue. We have three patients accrued to SWOG. I think it's actually open at a lot more centers, but and there's a fair amount of screening going, but just to put a note out for that study. Briefly, this study we discussed last time is still in discussion, not a lot of new updates on that. And then finally, I don't know if you wanted to discuss this at all, or I'm not premature yet. So this is the cognition study in prostate. We're still in discussion on. So that's it.
Thank you all for staying. Enjoy the evening and come prepared for tomorrow.